with my WebEx for some reason. It's quite new. Okay. Right. Sorry for the delay. If you guys are ready, we can start. So what we will do is I don't believe in spoon feeding you guys. So that's why I've asked you guys to come up with one slide each on the important common conditions, right, in psychiatry. Uh, and from there we will discuss, okay? All right. So whenever you guys are ready, just start, right? I think some of the questions you guys have asked will be covered in what we talk about today, but you can, I mean, and then whatever is not covered, we can discuss it lah at the end. Okay. All right. If along the way you guys have any questions, you can ask as well. You can ask it or type it up. All right. Okay. So anybody can just start presenting first, and we'll go from there.
Good morning, Doctor.
Morning.
Good morning, Doctor, and my fellow friends. So, I am Anissa. I'm going to start presenting regarding the MDD, which is the major depressive disorder. Next. Okay. So, this is the outline for my part, which is history, PE, MSE, investigations, and also the managements. So first for the history, we need to ask regarding the major depressive disorder symptoms, which we need 5 or more of these symptoms, which occurring within a 2 weeks period, and at least one of it must be either depressed mode or loss of interest. So the mnemonic will be DSIGA-CAPS, which include depressed mode, sleep, either insomnia or hypersomnia, interest, which is loss of interest, guilt, we can ask regarding the any excessive guilt, any feeling of hopelessness, and then energy, which usually they will have diminished energy, and also diminished concentration. And then appetite, it's usually lost, but it can be it can also be increase in appetite, and this may also affect their weight, either weight gain or weight loss. And then you need to ask any psychomotor agitation or retardation. And then lastly is suicidal ideation or attempt. And then after we ask regarding the MDD symptoms, and then we need to confirm whether these symptoms affect their social and occupational impairment. And then after that, we ask regarding the bipolar symptoms to rule out bipolar, which this one will be explained by my friend later. And then after that, we need to exclude other mental disorders such as schizophrenia. So we need to ask any hallucination or delusion. And then anxiety also, any symptoms of anxiety. And then after that, we need to rule out any drugs or substance abuse that may induce the symptoms that he or she having. And then lastly, we exclude any medical illness that may cause the symptoms also.
Yep, good. So the idea is that say if you clock a patient who has full MDD symptoms, okay, the full range, you have enough to diagnose MDD, and then they tell you they did have some hypomanic symptoms, for example, a little bit of increased energy, increased goal-directed activity, very active a few months ago, okay? In that case, what would the diagnosis be? If say you get a history of mania like some months ago, but now she's very, very depressed, what would the diagnosis be, guys?
Bipolar.
Yeah. So the diagnosis is always bipolar, okay? And when you say bipolar like that, can your differential still be MDD? Anybody?
Can.
Really? If you really? If you have diagnosed MDD, if you've diagnosed bipolar, it is already a bipolar illness. No more diagnosing unipolar MDD already. Understand not? So I see this repeated in your FPEs. I see students repeating this mistake again and again. Once you have diagnosed bipolar, MDD is out the window. PDD, persistent depressive disorder, is also out the window. Understand? Can I get some indication of understanding?
Okay, doctor.
Yeah, can I get some indication of understanding? Thumbs up or something. Just make sure like you guys get it, because this is very important. Okay? Once you get a history of mania, MDD is no longer in the picture. Any episode of any major depressive episode you have now is part of a bipolar spectrum. So it's part of a bipolar disorder. You can say bipolar disorder in depressive phase. You can say mood disorder secondary to general medical condition. Can say secondary to substance, blah, blah, blah. You can say anything else, but your bipolar and your MDD cannot be in the same group. Okay? The fact that you ever consider MDD as a provisional or a differential indicates that you have already ruled out the other pole, which is the manic or hypomanic pole. So once there is mania, MDD cannot mention at all already. The current episode can be, yes, a major depressive episode, but it's on the background of bipolar disorder. So it's still bipolar disorder in depressive phase. Faham tak? Clear, everybody?
Okay. Okay, doctor.
Yeah.
Yeah,
Okay,
doctor.
so this
Yes,
is
doctor.
super important. So that means that, say in your SBCE, in case you suddenly get the mania history like in the final minute, okay, the idea is you try to ask mania a bit earlier. Like say somewhere in the middle, you just rule it out first. Check, okay, just to check, you know, you're feeling very, very down now, but could you ever do you remember feeling very down, very the total opposite of this a few months back maybe? Have you ever felt the total opposite before? Lots and lots of energy, very, very happy for no reason. Have you ever felt that before? And you can ask that. And if the patient says no, then you can just go back to your full depressive clucking. But if the patient says yes, then you must divide your time already for the clucking, because then your diagnosis would be bipolar disorder, MDD is out. Okay? All right. So let me just give you an idea of the framework that I show people. I'll just share one slide with you guys, and then we shall use that framework for the rest of our revision. Okay? Hang on. Where is it? Okay. All right. Let me show you this for a while. If I can just share the screen with you just briefly, yeah. Then we shall use this framework for the upcoming yeah. Okay, can you see that? You guys can see my screen, okay, Ka?
Yes.
Yeah.
Yes, doctor.
Okay. Okay, so there's no such thing as this in your psychiatric textbooks, okay? This is something that I have come up with just to help you guys to think about psychiatry systematically. Which you will find is you see when you listed the depressive disorder criteria in your slide, it already covers a lot of this. Okay, so let me show you. Annotate. Okay. It's my annotating arrow. Okay, so can you see in all clucking, in all cases, it's useful to have a framework in your mind. Okay, so here in basically all disorders you come up with a big six. I call it a big six for you guys to help to remember. Okay, one big one is psychotic disorders. Okay, so that would be schizophrenia, schizophreniform disorder, brief psychotic disorder, Okay, that's psychotic disorders. There's one more here that is mood disorders. Okay, so mood disorders, it can be unipolar, like major depressive disorder or persistent depressive disorder, or it can be bipolar, which is both poles. Okay, then the third one is anxiety disorders. One more is physical disorders, meaning organic causes, right? Like hypothyroidism, brain tumor, things like that. Substance-related disorders. Okay, so anything related to medication and substance, like shabu, cannabis, things like that. And when you think about extremes of age, this last one, if your patient is very, very young, you want to think of autism, ADHD, child abuse, things like that, right? That autism, ADHD. If your patient is very old, on the other extreme, then you want to consider things like dementia. Okay? So in any sort of clucking, you want to consider this. That's why when you look at your presentation earlier, kan, you know, you ask about mood disorders, you get the whole history, kan? And then you guys mentioned rule out psychosis, rule out anxiety, and then rule out substance. It's mentioned right in your list, and then rule out organicity. Okay, so once you have taken out psychotic disorders, this is not schizophrenia. Taken out anxiety, this is not some sort of generalized anxiety disorder, and the patient's feeling depressed because of that. You've taken out physical disorders. Thyroid is okay. CT brain is fine. Substance you've taken out as well. The patient doesn't take any substance. Urine for toxicology is negative. Then DSM-5 allows you to diagnose a mood disorder like an MDD or a bipolar disorder. Okay, so that means that in any clucking at all, okay, you can resume sharing your screen. In any clucking at all, you should cover all these domains. If the patient comes with low mood, you need to think, yes, about mania, but if you look at your list there, you want to ask one or two questions about psychosis, hearing voices, unusual belief. Ask one or two questions about anxiety. Do you feel nervous all the time, worried all the time, right? Ask one or two questions about substance. You know, sometimes people when stressed, they take substance. You ever done that before or not, right? And then under any underlying medical illness. So you see these ones, the DSM-5 most of the time will require you to rule out all this. So if you remember things in all cases, whatever they present with, if you think about the big 6 domains that I tell you guys about, and you remember to ask one or two questions from each domain, then it's highly likely that you'll be able to at least come up with some reasonable differentials and provisional. Okay? Clear so far? Yeah, so far. So think about everything systematically. When you're clucking, think about the big 6, the domains. Okay. When you are investigating, like investigations here, kan, I like to divide it into biological, um, imaging, and psychological. Okay. So this would be psychological testing, not psychosocial, because there's nothing social about the skills you're doing. Okay. So biological will involve blood and urine. Imaging, you can involve radiological, like CT brain, MRI, things, chest X-ray, and you can involve electrical imaging, so ECG, EEG, things like that. Okay, then psychological tests. So you divide into 3. Management also, biopsychosocial, you divide into 3. So if you think about it systematically, then psychiatry becomes a lot easier to look at. Okay, carry on, Elisa.
Okay. So I will continue with the physical examination and also mental state examination. So for first physical examination, we need to do full examination, which include vital signs, which is temperature, pulse rate, respiratory rate, and also blood pressure. And then for the mental state examination, the mnemonic as we know is aseptic, which is ASEPTIC. So for the appearance and behavior for MDD patient, we need to see any eye contact and also their general appearance. Usually they might have a messy or weak appearance. And then for the speech, we need to see the speech and also the expression, whether they have no expression at all or they are sound sad. And then for the emotion, we need to see the mood and also the effect, which usually they are sad.
So be a
And
bit
then
careful with emotion. Emotion is for you guys to remember, okay? Emotion. But no mentioning of emotion in the exams because that's not a psychiatric concept. Yeah, the psychiatric concept is mood and affect. Emotion is to help you guys
okay,
remember lah. Okay? Carry on.
okay. Okay, and then we ask regarding the perception, any hallucination or delusion. And then for the thought content, we ask any suicidal thought. And then if there is, and then we need to screen with mnemonic of sad persons. Later, one of my friend will explain. And then ask regarding insight, which is the awareness, attribution of the symptoms to this mental disorder, and then the acceptance of treatment to these symptoms. And then ask the cognition, which is memory, which include the immediate erasure and remote memory, and then the concentration and also the judgment. Yeah, that's for LSE.
Carry on.
Okay. And then for the we carry on with the investigation, which like my doctor mentioned just now, we classify into three, which is biological, imaging, and also psychological. Sorry for that typo. For the biological, we do full blood count to rule out any anemia, which is organic causes, and then thyroid function test and calcium to rule out any hypothyroidism in this patient. And then we do liver function test and also renal profile to see the baseline of the renal and liver function before starting the treatment. And then we do fasting lipid profile, fasting glucose and also random blood glucose. And then we do ECG as the baseline, and then urine drug screen to exclude any drug related.
So what
And then
would
for
our
the
concern
psychology,
be with regards to say you want to do, how about your renal profile tak buat kah?
we do. Sorry, I didn't put in there.
Yeah, in fact, your renal profile may be even more important than LFT. Some of the LFTs are important in certain medications, certain SSRIs, but the most common SSRIs, the most common antidepressants have an issue with hyponatremia, right? Hyponet.
Mm-hmm.
So your hyponatremia, so therefore your renal function is actually quite important because you want to know the BUs lah, your electrolytes. Okay. ECG, what's our issue with ECG?
Um, for the baseline, before starting the management,
Okay. Yeah, one thing, but what there's what kind of risk are we talking about when it comes to starting management? Any particular syndrome kah or what?
Prolonged QTC.
Prolonged QT lor. Or prolonged QT and also any arrhythmias from electrolyte imbalance. Okay, so of course you want a baseline to make sure. Okay, that's usually if you're starting SSRI lah. When people start older ones like amitriptyline and all that for elderly people, you also want to check the ECG because they can be, those can cause arrhythmias as well. Okay, good. Carry on. So back depression
yeah,
inventory or Hamilton score for depression lah. That is that huh? Can.
yeah.
Okay. Carry on.
And then for the management,
Mm-hmm.
we need to decide whether the patient need any hospital admission or not. So we need
Mm-hmm.
to see if the patient has any risk of suicidal or homicidal, or whether this patient is able or unable to care for him or herself. So we need to see the condition. And then second one, we need to give management biopsychosocial approach, which include pharmacological and also non-pharmacological.
Mm-hmm.
So for the pharmacological, it includes antidepressants such as SSRI, SNRI, NASSA, and also TCA. And then also we can give mood stabilizers such as the lithium.
Okay,
And
chop,
then for the
chop,
non-pharmacological,
chop. One
can be
moment.
psychotherapy, which is cognitive behavioral therapy, interpersonal therapy, supportive therapy, problem-solving therapy, psychoeducation, exercise, and also relaxation. And then, if the patient is unable to tolerate or unresponsive to
Okay. Uh-huh.
unresponsive to unresponsive to the medication, so we need to do electroconvulsive therapy.
Right. Right. So when we talk about antidepressants, what is the most common one that we use that is generally quite safe?
SSRI, which is the sertraline.
SSRI lah is a very reasonable one. Okay. Now, say if you get some bipolar symptoms, and the mood stabilizer, do we still start an antidepressant? Anybody?
Mm,
What do you guys think? sangat-sangat depressed now, but got history of bipolar symptoms. I mean, history of manic symptoms or hypomanic symptoms. Do we still give an antidepressant?
No,
No.
doctor.
No,
Yeah.
doctor.
You give a mood stabilizer, okay? Once you have established bipolar disorder and MDD is not in the picture, you give mood stabilizer. Mood stabilizers have effects on the depressive features as well. If the depression is part of bipolar disorder, then mood stabilizer has some mood regulating effects for the depressive episodes as well. Okay, so once your diagnosis is bipolar disorder, the treatment is mood stabilizer. Full stop. All right. There are some special cases where certain group of patients who have a sudden episode like suami meninggal in grief, right? They may need a short period of antidepressant, but that one is on a pakar level lah. It's on a specialist level decision. You will not be expected to make this kind of decision. All right. So it's enough for you to know that if it's bipolar disorder, the treatment is mood stabilizer. If it's unipolar depression, then you treat with antidepressant. Okay, so you can see how important it is to ask for mania in any presentation that looks like depression. Okay, and I think under your non-pharmacological area, actually, there are some things that you can take out of there that you do generally for everybody. Contohnya psychoeducation, because psychotherapy is a very proper type of therapy that you do with a therapist, with a clinical psychologist. So macam CBT, interpersonal therapy, all this you do with a proper therapist, like a proper clinical psychologist, kan? But psychoeducation, exercise, relaxation, all these are actually outside of psychotherapy. It's like general measures, you know, you can put it under general measures like self-care, psychoeducation, getting enough rest, things like that. So those things, actually you psychoeducate all patients. In fact, your answer should be psychoeducate for everybody first. Okay, then after that, psychotherapy is a separate specialized thing. So macam CBT like that lah. CBT for depression is a good thing. It's a good one. ECT also is when you want rapid reduction of symptoms. That's the most important one. And then after that, if they are not responsive to pharmacotherapy. So desired rapid reduction of symptoms is the most important. Say you admit the patient, have you guys heard, if you admit the patient, what do you need to do if you admit a suicidal patient? You need to put them on what kind of caution? Have we talked about that before? No, we've talked about that before. Suicidal caution. Have you guys heard of it? Is everybody okay? Or is my microphone problematic again? If you decide to admit a patient, you need to put a patient on what? On suicidal caution. Have you heard of it before or not? Would that have been covered in your seminars last year? I was not with you last year, so I don't know. Suicidal caution. Heard of this?
Never heard.
Really? Oh my gosh. Who
I
took your seminar last year?
don't know. Forgot.
Who took your seminar last year? Okay.
This one not seminar, doctor. This one is lecture.
Really? There was no seminar on suicide and emergencies last year. Like your psychiatric emergencies, it's not suicide in there? Or did you not have one on suicide on psychiatric emergencies last year? Tak ada, is it?
Yes, I think so.
Okay. Common sense. If you admit a suicidal patient, what is the kind of precautions you need to take? Let's think about it. Common sense. You admit a patient who is suicidal into a ward. What are the kind of precautions that people need to take? Agak-agak.
Any risk
Somebody.
for reattempt, doctor?
Yeah, so you want to watch out, right? You people keep them away from things. Yeah, some people have padded rooms if they need some to prevent self-injury on the walls. You hide sharp objects, right? You don't give any access to things for hanging yourself or sharp objects, right? Yeah, so this is all called suicidal caution. Understand? This is all called suicidal caution. And by right, the nurse needs to observe every 15 minutes. Okay, so in the exam, if you have this type of patient and you have to admit, right? You admit to the ward in view of risk to self, you want to hospitalize, right? You do need to put on suicidal caution. Okay, SSRIs take some time to work. So in very, very suicidal patients, you start with apa? You start with, you can actually consider giving ECT. Understand? SSRI takes some time to work, right? Any estimate how long? Anybody?
More
4
than
to
2
6
weeks.
weeks.
Yeah, at least 2 weeks and above, right? So you won't be making any miracles overnight with your SSRI. So actually when you admit, you want to make sure patient is safe and you want to get them better faster, engage with social support, try and get the family on board to support the patient in the times of crisis, right? And you may want to consider ECT to work on the suicidality because ECT reduces suicidality. Okay, so you put on suicidal caution, you start an SSRI, and you consider ECT if the patient is very, very suicidal. Understand? Are we clear so far?
Yes, doctor.
Yes, doctor.
Are we clear? Okay, good. Now, there are a couple of questions here. Liana asks, if patient mentions he has hypomanic symptoms but less than 4 days, can we still diagnose bipolar disorder? Now, if you are talking about exam setting, we will probably not be so nasty to you to give you some of these symptoms that don't fulfill the criteria and make you pening kepala lah, okay? But if it does happen, in real life, sometimes it does happen, right? You can say, because hypomanic symptoms, one of the criteria is not just the duration, but it's also whether it interferes with occupational function, that's one. And the other one is also the intensity of it. So if he can tell you very clearly that he has all these hypomanic symptoms, and then it's like 3 days instead of 4 days, you can actually mention bipolar disorder. Because in that case, you definitely cannot be just saying that it's MDD already. Usually, if you have those symptoms, it's quite significant lah. And it's like after a few days, then it's significant enough for patient to remember. If he just has 1 day, he probably won't tell you that, oh, I had this 1 day like 3 years ago where I had this. No, it's usually a certain number of days that he'll recall. So you can diagnose bipolar disorder, but you can say that there's an issue with the criteria there lah. So yeah, I would say you still can, but probably in the exam setting, we won't do this to you lah. Okay, we won't do this to you. Yeah, but you can. If the provisional diagnosis is MDD, can persistent depressive disorder be one of the diagnoses? Depends on how long your symptoms have gone on for. The problem with have you guys seen the MDD criteria for the persistent depressive disorder criteria? Anybody? If you look at the persistent depressive disorder criteria, right? The duration we are talking about is how long?
Yes.
We're talking about 2 years, kan? We're talking about 2 years, and we're talking about a lesser intensity of symptoms. The symptoms are lesser. In fact, you don't need you only need like 3 criteria. You need to be depressed plus 2 of the other criteria, right? So, say if you have a patient, if you look at the number of the criteria, then MDD and PDD kind of can't really fit together already. Because if say if you only have depressed mood plus 2 symptoms for 2 years, yes, you can say that it's PDD, but you don't have enough to say that it's MDD. Okay? But say this patient has more than that, depressed mood plus 4 symptoms, so she has 5 symptoms for 2 years, then maybe you can still argue between MDD and PDD lah. That is the simple answer lah, I would say. Make sense or not? Make sense or not?
Sense.
Okay, okay, so you must just know that PDD, the number of symptoms are lesser and the duration is long. But some people, yes, they have MDD for 2 years. Okay, so you need to sort of see how many symptoms there are and to what extent it to what extent it occurs. Yeah, yeah. Okay, but certainly if you have symptoms that are serious enough, you should be diagnosing MDD first lah, rather than PDD. PDD is more for a milder version that goes on for a longer time. Okay, all right, good. Any questions with regards to depression? One of the questions you guys sent in the Google form is, most diagnoses require the symptom to fulfill a specific time frame. And it's similar to Hanisa's question, where the presentation is suggestive of certain diagnosis but has not yet fulfilled the time frame. Can we establish the diagnosis for the patient? Now, my answer for this will depend. If you are talking about, say, MDD that went on for 12 days, almost 2 weeks, okay? And you don't have an alternative diagnosis for it, there's no substance, there's no general medical condition, no anxiety, no psychosis, okay, then you can diagnose that and say that mention that you would like to observe for the fulfillment of that time frame punya criteria. That is one situation. The other situation where I think you should not do that is if, like, say, okay, how long, what's the time frame for brief psychotic disorder? How long? Anybody? How long does it take? Brief psychotic disorder, how long? What's the time frame?
1 day to
1
1
day
month.
to 1 month.
1 day to 1 month. And then longer than that, until 6 months would be what? What disorder? Yeah, schizophreniform, right? So more than 6 months, it will be schizophrenia. So if you say that somebody has the full criteria, looks really like schizophrenia, but it doesn't fulfill the 6 months, there is an alternative diagnosis which is schizophreniform. So I wouldn't be expecting you to say, oh, I would diagnose schizophrenia, but wait for 6 months in this type of case. I would expect you to say schizophreniform disorder because there is an alternative. So if they don't fulfill the time criteria, but there is no other alternative, and this is the best one, you can say that, okay, it is this, but the time frame is almost reaching the time frame, not quite there yet. But if there is an alternative diagnosis, contohnya, schizophreniform disorder or brief psychotic disorder, there's an alternative, you should be using the alternative diagnosis and you should not be talking about schizophrenia when it's less than 6 months. Faham tak? Are we clear?
Yes.
Okay, so it depends on whether there is any alternative or not. Okay? All right. If there's no alternative, then you can say lah, I would like to give more longer time frame, but this is suggestive of this. Okay. Somebody asked as well, for SCBE, if we rule out medical causes or drug-induced mood disorder, psychotic disorder in the history taking, can we still put a differential as mood disorder secondary to drug or medical induced? Okay, let's say you have ruled out organicity and you have ruled out substance. The patient says she doesn't take, right? It depends again. I would still put, if the patient denies current use, I would still put it there if one, the patient has history of use before. Two, there are any other high risk behaviors that indicate that there may be some ongoing use, I would still put it. Three, if the patient has other medical conditions that may cause them to be on medication that lead to the symptoms, so medication-induced psychotic disorder or medication-induced mood disorder, I would still put those as differentials. If the patient denies any physical symptoms, I would still put organicity, number one, if you find anything on neurological examination. Number two, bear in mind that some neurological symptoms cannot be derived from history. Some of it is like from thyroid examination, from CT brain, blah, blah, blah. So you can actually put organicity. Number 3, that I think this one is the most important. Any first presentation, you should always consider organicity. So I personally do not penalize anyone, even if the patient says, oh, I don't have this, don't have family history, don't have, I would not penalize anyone for considering organicity as a differential. Understand? Especially if it's first presentation, if it's a very acute presentation, say within 1 month, the patient is hallucinating a lot, there's a decline in work function, very, very fast onset and very, very sudden change, right? Very acute. I think you should always still consider organicity. So I would say substance and organicity should always still be considered. It's probably safer to answer this than answer schizoaffective, where you need some very, very specific criteria to diagnose. Is that clear? Is that clear? So not all organicity can be obtained from history. Sometimes some things are on investigation. And also, there are other clues to indicate that there's organicity, not just physical symptoms, but whether it's acute, very sudden onset, very sudden deterioration, first presentation, all first presentations, you must consider organicity. I think that's the main thing. We don't want to overdiagnose psychiatric conditions and miss out on major illnesses. I've had a patient come to me for 10 years. After 10 years of being treated as by a private psychiatrist, okay, for a depression that never seemed to improve. So got referred to us for second opinion, and we did his thyroid function. His thyroid was the lowest thyroid I've ever seen in my life. Okay, and that is why he was so slow, and he had some skin changes, and he was like just almost like you talk to him and there's a whole fog. There's a whole fog and a cloud between you and him. He doesn't really seem to get it. And that was because of that. So when he was treated with thyroid hormone, a lot of the symptoms actually began to improve after 10 years, okay? So I think that's important. Organicity is always something to consider. Okay, so that's one more of your questions, I think, for that. Someone also asked, in management of MDD, it has acute and maintenance phase. If patient has not high risk for relapse, no family history, this is the first episode, patient do not need maintenance therapy. Possible. So if it's a first episode, and then, for example, the stresses, like previously very, very stressed with this job, has moved jobs, now not so stressed, right? There is a improvement in the life situation, and it's a first episode. Yes, after being stable for 1-2 years, you can consider tapering off. You can consider tapering off the antidepressant, trial of tapering off later. But usually if the depressive symptoms come back, then we start back the medication, and this person may likely need long-term maintenance therapy lah. But in some cases, some people you can try to taper off. The key word is to trial tapering off antidepressants. Okay? Understand? I hope I answered that question to siapa-siapa yang tanya. Okay not? Are we leaving anybody behind on the boat? Has anyone fallen off? Are we okay? Yes, okay. There's a few questions on MDD here. I might as well answer lah, since we're on the topic. For mild MDD, the management is psychotherapy, psychosocial intervention, plus minus pharmacotherapy. So what is the indication to start with antidepressants? The intensity of the symptoms, whether they are at risk to themselves or risk to others. For example, somebody postpartum depression, when you are thinking of harming your baby, or when you're highly suicidal, right? So in cases where there's high level of risk and where the symptoms are very intense or the patient is actually keen for medication, then you can start lah. Mild depression would not have all these features. So in those cases, yes, you can try psychotherapy first. All right. I hope that answers that question as well. If it doesn't, please feel free to type a follow-up question. What is the MDD with psychotic features, which antidepressant is preferable? Same across the board. Just start any SSRI you prefer. Okay, in very bad usually if the mood improves, then the psychosis goes away. But if in some cases where the psychosis is very vivid, some people will add antipsychotic. So mood antidepressant with an antipsychotic, you can. But generally speaking, any antidepressant lah, any antidepressant you use to treat MDD with no psychosis, you can do it. If the psychosis is bad enough, you can consider a small dose of antipsychotic. Okay. What are the drugs given prior to ECT? Can any of you tell me what are the drugs given prior to ECT? What is given for patients? Any change
Muscle
in
relaxing.
yeah, muscle relaxant and two things.
Propofol.
Yeah, so propofol or a general anesthetic. Which one is given first? Anybody? Which one is given first? Anyone? You cannot. Okay. All right. So, what medications? I'm not entirely sure what this question indicates. What kind of medication? These are the two drugs given prior to ECT. There are no changes in hypertension or DM meds or things like that. Everything continues as usual, but you are kept nil by mouth in the morning lah, at least. In most cases, your psychiatric medication can continue, except two types. Anyone have any idea which medications can affect the seizure threshold? Because in ECT, you want a seizure, right? So a medication that reduces the seizure threshold is the one that is that we want to avoid. No, a medication that increases seizure threshold makes it more difficult for you to have a seizure. So which are the two that will make it more difficult for you to have a seizure? Yep, benzodiazepines, and not just lithium, but any mood stabilizer. Kan sodium valproate is an anti-epileptic. Lithium also has some anti-epileptic. Has some increasing of the seizure threshold. So in these cases, it doesn't mean you stop. Different psychiatrists practice differently. Some will withhold completely. Some will adjust the dosing. Some will adjust the timing of the dose. So it kind of depends. That is a specialist level decision. It's enough for you guys to know that mood stabilizers and benzodiazepines can affect the seizure threshold and make the ECT less effective. So you have to omit benzodiazepines the night before. And for mood stabilizers, because they may be very manic, so you cannot necessarily omit everything, you need to make adjustments. Okay? So that's a question about ECT, which we'll cover one shot here. Right? Can a person who has established MDD and develop anxiety symptoms that fulfill GAD, can we have two diagnoses? Yes, you can. Yes, you can. Unless later on, right, like say his MDD is actually recovers, and then later on he gets GAD. No, scrap that. A person who has established MDD can develop GAD. Yes, full stop. As long as you fulfill criteria, you can. So that would be a dual diagnosis condition. Yes. Okay, I hope that answers the question. All right. Any further questions? Is everybody clear on MDD so far? Are we okay? If you're okay, we move on. Okay, good. So I'm laying the groundwork. I don't expect us to take super long for all the others, but I want you guys to have a framework of how to think about it. Okay, all the 6 domains have a
Hi,
framework of how
Doctor.
to think about investigations. Yes?
I would like to ask
Yeah.
I would like to ask a question. So regarding the risk for regarding the suicidal risk, are we still using the sad person or we
Haha,
have
very good question. Why do you ask this question, Nafisa?
previously we are using this, but I think one of the junior told us that it's not being used anymore. So I would like to clarify this.
Ooh, very good. Very, very good. Okay. This is the traditional way. Okay, this is the traditional way of assessing suicide. Probably you won't be super penalized also if you were to say a sad person score. Okay, but if you look at the sad person score, if you look at it lah, let's look at sad persons. Let me pull it up for you guys. Okay, or do you have it somewhere in your slide, sad persons? If not, I'll pull it up for you, and then we'll have a look at it. Is it anywhere on you guys punya slide? Or okay, or I'll pull it up for you guys. You can do that as well. Okay. Let's look at it, huh? I show you. All right. Now, let's look at this sad persons. Huh? By right, they say if you score a high score on this, you are at higher risk. Okay. Let's say you have, let's say you are a guy. You are a guy who is 18 years old, who is of course single, right? Who is of course single, but who is feeling depressed. Okay, so you have one SAD, right? And then maybe SAD up here, four lah, a score of 4. Okay, but then and then you've been drinking more, so you have E5, and then you have a certain. It was something you did impulsively, because of a sudden breakup of a relationship, and then you made an attempt. So on this score, it does seem like you score higher, okay, compared to say a female who is 25 years old. She doesn't score anything for S and A. Okay, maybe she's feeling depressed. She scores 2. Okay, but then she has nothing else there. And actually, in the back of her mind, so for this boy who scored 5 on sad person, he actually did something impulsively, and then after that he regretted it and he don't intend to do it again. But this lady who doesn't fulfill all these criteria, she has some social support. Okay, like say for N, she's got a lot of family, she's got a lot of friends, but she's still depressed, and you don't need a reason to feel depressed. So she's a female who is 25 years old, who has a lot of social support, who doesn't tell you her future intent. You see the S at the bottom, stated future intent. I actually want to commit suicide again, but I don't tell you, so I keep quiet. Okay, and I can still be very rational. I give you R. I say I can still be very, very rational. I can make up the story. I can be more rational. So if you think about it, this person only scores 2 on your sad persons. Now, between the two, who do you think is more high risk? If you are a highly intelligent person and you hide your symptoms, who do you think is more high risk?
The girl.
Yes, exactly. So that is why we are moving away from using sad persons. You can use sad persons as a way to screen for certain risk factors, but the better assessment of suicide is your own assessment of what this patient did before, did during, and after the attempt. So before, meaning that did I make any plan? Did I write a suicide note? Did I buy lots and lots of medication and kumpul it together? Did I plan on where to buy pesticide? Right? Did I wait for a time when nobody was at home? What kind of planning did I do to reach this stage? Number 1. Number 2, during the event, did I immediately regret it? You know, some people swallow all the pills and then immediately regret it. The people who jump off the San Francisco Golden Gate Bridge say, those who survived said actually the minute they jumped off, a lot of them said they immediately regretted the jump, right? So was there any regret after that? Did I call somebody? You know, I swallowed the tablets and then, oh my goodness, I regret. I call my mom. You know, that kind of thing. So what did I do? Or did I go and tell my mom? Okay, like you know, they they tengah marah, right? They go to the living room and say, I'm going to kill myself. Then they masuk the room and then they go and try and hang themselves. But the family all comes in quickly. So that kind of attempt is a bit different from somebody who waits until there's no one at home and takes the tablets or tries to hang themselves. Okay, so that's during the event. Did I take any alcohol to give myself more courage? Any alcohol or drugs to give myself courage to do it? Okay, then after that, so now how do I feel? After I'm in emergency, I have survived my suicide attempt. How do I feel about it? Do I feel glad or do I feel, I think I could do it again? I don't know lah. I still see no meaning for life. Or am I very touched that my parents came and all my friends came? Am I very touched and do I feel regret? Do I intend to do it again? Like when I go home, do I still have access to the alcohol, to the drugs, to the tablets, to the pesticide, to the hanging punya stuff, right? Do I have any social support? So that is after. So your assessment of before, during, and after is a better assessment of suicide. Okay, so yes, you can use the modified sad person scale. But let me show you. The one that we intend, we use a lot more is this now, which is what we call safety. Okay, let me show you. During the exam, you can mention sad person. Okay, we won't exactly say penalize you completely for it, but we would like you to be aware that sad persons is not super sensitive. I can't seem to find a clear image for you guys to see. Hang on. Let me see. I'm glad you asked the question because I was actually thinking about bringing it up at some point. Let me show you. This is the one that we discuss in psychiatric settings lah, in government hospital now. Okay, let me show you. Can I see it? Oh my gosh, all the images are so small for you guys. Okay, let me pull this up for you. Okay, this is called safety, SAFE and T. Okay, you can find it online as well if you're not sure. So these are some ways of assessing a suicide attempt. Okay, it gives you some clues to before, during, and after. So identifying risk factors, and then the assessment of the risk level and possible interventions and things like that. So, like I told you that you can search it up online. It's called safety. Okay. So I hope you see why sad persons is not super sensitive. You can mention it, but you also should mention other sort of assessments like safety, even the back suicidal intent scale, other things to help you in your diagnosis. And your own clinical assessment, your own clocking is actually better than just using a scale to so-called predict suicide risk, right? Your own assessment is better. Somebody who has made a lot of planning and who takes substance to get themselves into the courage, I mean, who to give themselves courage to do it, who hides the attempt, who makes some plan to hide the attempt, and who feels nothing after surviving, and who still has access to the weapons and all that again later, would have much higher risk, right? Or somebody who's not forthcoming with you, just keeping quiet about it, but actually secretly harboring the suicidal thoughts is at much higher risk than somebody who doesn't have all these things, who's like had this massive breakdown, emotional breakdown, and then just did something impulsively without thinking, without really planning it. And then after that just feels like, ayo, I don't want to do this again, and it's so such a torture to be in hospital. That kind of thing is two different cases, and they're very one is definitely higher than the other, even though this one would not score highly on the sad persons. Understand?
Yes, doctor.
Yeah, so sad person should not be your only answer. You should answer together with other things like my own, you can say your own clinical assessment of the patients before, during, and after, the whole suicide attempt. And then other scales, other strategies like safety and back suicidal intent scale can be helpful. Okay, so you can answer sad persons, but not alone, not sad persons on its own. Okay, good. Sad persons is very hard to get rid of because it's so convenient and everybody loves it. It's been around for so long, but it's not very sensitive, so we have to move on. Okay, good. Carry on. Okay, let's go briefly through bipolar disorder. Haswani, you may not need to repeat through all this, just mention the time frame. You don't have to go through all the symptoms, I mean all these manic and MDD symptoms, but just talk to us about the time frame and the criteria at the bottom, 4 to 8. Okay.
Okay, doctor. Thank you. Good morning, everyone.
Yep.
So for this part is bipolar disorder. So as we know, bipolar can be further divided into bipolar type 1 and also bipolar type 2. So in bipolar type 1, mainly what we need to diagnose patient with bipolar type 1 is the manic symptom, in which it occur for 1 week duration. And from the criteria in DSM-5, we need 3 out of 7 symptoms to be fulfilled. So as being mentioned just now, so these are the symptoms for manic symptoms, which with the mnemonic of thick fast. And then for hypomanic symptoms, they will have 5 days duration of the symptoms. And in hypomanic symptom, these symptoms will not interfere in their social or occupational functioning. Sometimes they don't even need admission, and there is no association with psychotic symptoms. And then for bipolar type 2, usually what we need to fulfill is the MDD symptoms and at least 1 episode of hypomanic symptom. So for MDD, as what being explained by Anissa just now, we will need 2 weeks duration of the MDD symptoms, 5 out of 7 symptoms. And then proceed with the symptoms, whether the symptoms cause marked social and occupational impairment, which this will further guide us to differentiate whether it is manic symptoms or hypomanic symptoms. And then we can also ask regarding the psychotic symptoms, just to rule out any other psychotic disorder that may also being concurrently happen with bipolar disorder. Other than that, we need to also rule out any substance usage to rule out substance induced disorder. So what we need to ask whether patient before the onset of symptoms, did patient took any substance, or maybe previously they have history of substance usage. And then we also need to ask regarding and underlying medical illness, which can give us some idea about the medication or maybe medical illness that lead to mood disorder. And then we also have to like ask regarding the symptoms, other symptoms lah, review of symptoms system. So we have to ask whether the patient have symptoms of hypothyroidism and etc.
Yeah.
And then
Okay. So question, if somebody presents to us with mania or hypomania, can we, but no MDD symptoms, can we diagnose bipolar disorder?
can.
Kan? Can lah, actually. So you don't need to go and dig for MDD symptoms banyak-banyak. If there is, you do need to ask, but it's not necessarily wajib to diagnose bipolar disorder, okay? All right, good. So if you look at the bottom questions, you are covering the different domains, right? Remember the domains I told you about? This is a mood symptom case, okay? But you ask about psychosis. You should ask about psychosis, all right? Because in some cases, then your differential can be schizophrenia instead of bipolar in manic phase with psychosis, right? Psychotic features, no? It can be that. You need to ask about psychosis. You need to ask just one question, maybe about anxiety. Make sure this is not like due to some agitated state from extreme anxiety, right? You need to ask from the domains. This is not an extreme age patient, too old or too young, so there's only 5 domains. You've got a mood case, you're asking for psychotic features, asking anxiety symptoms, asking for substance, and asking for organicity. Understand? So in all cases, just go through them. Because if you are like blank, you're running out of questions, actually think about it. It's like a psychiatric systems review where you cover all the domains. Okay? Just like in medical, you have a medical systems review, kan? 1 or 2 questions from other symptoms that are may or may not be related. So in psychiatry, you have a psychiatric systems review in a way. You just go through that big group of 5. And if it's elderly patients, then another additional group is you need to ask about memory problems. So cognitive impairment and things like that. Okay? All right. because in elderly, dementia can be another differential diagnosis for you. All right. Okay, carry on.
Alright, so carry on to PE and MSE. So we
Mhm.
need to do full physical examination and also vital signs examination. So for full PE, we need to rule out any other organic causes lah, any underlying medical illness. So that's why we need to do full PE. And then for MSE part, because Anissa already mentioned regarding the MDD, and then I will just
Yep.
focus on the manic MSE findings. So
Mhm.
from the appearance and behavior, so we have to like first see the eye contact, and then usually patient in manic phase they will come very energetic, and then the attire is quite important also, because usually in manic phase they will um oddly wearing some oddly assorted clothes, such as like their shirts different color with their trousers, or maybe bright color they will like wearing something like bright color. And then we need to look for their hair, is it like comb very neatly
Yep.
or not. Yeah.
Yep.
And
No
then
worries. You may not need to elaborate greatly in all.
uh
Just go through briefly.
okay, all right.
Ah.
And then for the second part, which is speech part, usually in manic phase, they will have a pressure speech. Okay, we need to see for pressure-free speech, and then whether patient have a high rate of speech, and then also the um the call it talkativeness. They become more
Yep.
talkative.
Yep. Good. Move on.
And then and then for the emotion or mood and affective, we need to see whether there is a liability in their mood and affect, and then whether the effect is coherent with the thought, and usually not really have the derealization and depersonalization, but we still need to ask patient. And then for the thought content, usually in manic phase, they will have this flight of ideas, and then they
Yep.
will have grandiosity
Yep.
thought. Then the flow might be irrelevant. And then we need to ask regarding the next component, which is the perception. So we have to ask regarding any hallucination, any delusion. And then for
Yep.
cognition,
So
we
cognition
test their
insight.
memory, orientation, attention and concentration,
Yep.
confabulation, and also judgment.
So cognition and insight would
Ah,
remain the same lah. So you don't have to go over it again.
yes.
Yeah, it's the same as
Okay.
other
So
conditions, right?
insight would be
So you want a quick recap of
yeah.
what you would want to see in mania. Okay, so the speech is of course fast a lot, right? The appearance is very memorable. Okay, and then the mood is labile. It can go up and down, up and down. Okay, and then the thoughts would be grandiose. When you say flight of ideas, that's part of mania as well. So that means that if you're suspecting a schizophrenia, you want to talk about a case of schizophrenia, you don't put in flight of ideas. Okay, flight of ideas and pressure of speech are when you are trying to sell a bipolar case or a mania case. Okay, all right, carry on. The investigation seems similar to
Yes.
MDD as well.
Mm-mm.
Yeah, renal profile is particularly important. And why would
Yeah.
that be important in this case?
Because patient will be started on lithium later on, so the lithium will be excreted through the kidney, so that's why we need to do renal profile
Yep,
prior to
yep.
the
Yeah, very good. Anything you want to add for this part, uh, Haswani? Actually, the screening is similar lah, but lithium, very good, is renally excreted, so therefore you need to know. Okay. Um, um, and then for valproate, for example, you can have some transaminitis from it as well, so you need to know that. Some people have thrombocytopenia from valproate, so that's why you need to do an FBC. Okay. All right. But say if somebody presents with mania for just 7 days, 7 days of mania, but nothing else, and you are worried about some sort of infection, then your FPC is also to rule out infection kan? Your ABC is also to rule out
Yes.
infection, and then there may be some role for something like a lumbar puncture. Why?
Meningitis.
Some sort of meningitis or some sort of encephalitis. Yeah. Okay. So I think that's important. If something is very acute, a few days to a month of symptoms, like very, very acute, you do need to consider it, especially very, very extreme changes in behavior. Yeah. So urine toxicology is one more. You think about substance, and then organicity, you do want to consider at some point a lumbar puncture, maybe if it's very acute. Okay, carry on, Haswani.
Okay, I'll move on to management.
Yep.
So in management, we have to
Oh, hang
decide
on.
whether patient.
Hang on, back depression inventory ka. What do you guys know of any screening for mania? Any scale for mania? If the patient doesn't have depression symptoms, you don't have to do a BDI kan? Young mania rating scale, that's an option. Okay. So for mania, you do a young mania rating scale. Yeah, good, good, good. Okay, carry on, Azwani.
Okay, thank you. And then for the management part, we need to
Mhm.
decide whether this patient need to be admitted or not by the risk of harming themselves or maybe harming the others. And then the pharmacological therapy will be divided into acute phase and also maintenance phase. So for maintenance phase can be either monotherapy or combined therapy. So if monotherapy, the common drugs used is lithium or lamotrigine. If combined therapy, so we can use lithium and valproate or lithium plus valproate plus SSRI if patient presented with depression symptoms also lah. But if for maintenance phase, patient there are few types which further divided into first line and also second line. And the first line will be lithium, olanzapine, quetiapine, and aripiprazole. And this treatment should be continued for at least 2 years.
Right, where did we get
And
this management from, Azwani?
from previous lecture,
Oh ya kah? Who gave you the lecture, Dr. Azizah kah? Siapa
bukan.
bagi? Siapa bagi? Anyone remember who gave you your lecture on this? Ada siapa-siapa ingat tak? Tak ingat ke? Alright.
Prof Ismail, doctor.
Oh, okay, okay, okay. Okay. Prof Ismail gave you the lecture kah on this? Okay, okay. Prof Ismail is super, super experienced lah. He is giving you a lecture on pakar punya level, actually. Okay. Let's clear the slate, clear your mind a bit. I takut this one it will be a bit difficult for exams. I mean, in terms of being very clear about the management. Okay. Bipolar disorder, what is the mainstay of treatment? The main
Mood
medication.
stabilizer.
Exactly. Mood stabilizer is the mainstay of treatment. Okay. If you can maintain a patient on just mood stabilizer alone, no need to be combined therapy. Combined therapy is like pakar level already. So at your rate, what you need to know is mood stabilizer, full stop. That's the super important thing. Okay. But sometimes mood stabilizers take some time to work, just like SSRI takes some time to work as well. So what can we consider for this patient? Kalau sudah admit, we can give what?
ECT.
ECT. Okay, okay, those both are correct. Okay, ECT is one you can consider. Okay, so in this case, you see, the management for MDD and bipolar macam quite the same if you hospitalize, right? You give SSRI or you give mood stabilizer, but sometimes it takes some time to work, so you give ECT. Okay, now, sometimes another option is actually to give antipsychotic. Because when you give antipsychotic works a bit faster. And what it does is the second generation antipsychotics, just like the olanzapine and quetiapine that is mentioned here, right? They have mood stabilizing effects as well. So in these cases, you can give antipsychotic to help to settle down the mood faster. Okay. Upon discharge, you can opt to continue with both of these medications. Or in some cases, people will opt to taper off the antipsychotic and try to maintain on monotherapy only. Antidepressants, currently we do not give to patient together with mania medication. Okay, so your second star over there, we do not lah. This one I think is very, very specialized pakar level decisions that he's teaching you. But I think for your level, so we remove the confusion. Mood stabilizer. Sometimes you add in antipsychotic. You can continue maintenance on both, or sometimes people try to taper off the antipsychotic and see either way. And ECT is also an option for more rapid response. Okay? Are we clear? At your level, I think that is more than enough to know. Are we clear?
Yes, doctor.
Yeah. Okay, we are clear. That's what you need to know, I would say. So don't worry about like this pakar level punya decision. Okay? That's all you need to know. All right. Treatment can be as long as it's needed lah, actually. Okay. So I would say that bipolar disorder is one of the conditions, not like MDD, where you can just try and taper off medication. Actually, you do need to continue lah. You do need to continue. It's likely like schizophrenia, a bit, it's more on the long-term type of treatment. All right? Okay, good. Carry on.
And then pada non-pharmacological therapy, we can do psychoeducation, and then we can ask patient to do some mood diary, and then also interpersonal and social rhythm therapy. This one is whether to teach a patient how to cope and regulate with the mood in their daily living. And then we can also do cognitive behavioral therapy, family therapy, and also support.
Good. Okay. Any questions? Anybody? Are we good? Are we okay? If we're okay, we move on. If you guys have any questions, you just type it in. Yeah, someone has a question.
Doctor, I have a question.
Yes.
Let's say just now you mentioned that the first step when it comes to acute mania, we give a mood stabilizer, right? If let's say the symptoms of mania is very severe, can we straight away start the patient with antipsychotic? Or we would have to go for ECT?
What? Straight away start the patient with what?
I mean, if like, the first line treatment when it comes for acute mania is mood stabilizer, right?
Mm-hmm.
So if let's say the symptoms we see it's very severe,
Mm-hmm.
then just now you say the mood stabilizer will take some time to take action.
Yeah.
So
Yeah.
can we right away start, like instead of giving the mood stabilizer, can we give antipsychotic?
You can give antipsychotics straight away. In fact, you will see that being done in hospitals in Sentosa and sometimes in SGH. You can give straight away. But you give both.
Means mood stabilizer together
Yeah.
with antipsychotic. Okay.
Yeah, you can that or if because otherwise why wait, right? Why wait to give the mood stabilizer unless there's any problem, any contraindication? If not, just start straight away. Yeah, just start straight away. If the mania is very, very severe, you will find that sometimes patients require quite high doses of a combination therapy to actually settle down. Okay, another thing that you guys yeah, you can do that lah. You can do that. You can start the antipsychotic straight away or start with ECT straight away and just start the mood stabilizer as well. So mood stabilizer is a long-term thing. Another thing that you guys should consider is actually benzodiazepines. In the case of MDD, people can use benzodiazepines to help with sleep, to help to settle down any agitation, and you can do that for mania as well to settle the patient down. But that will require short-term use. You want to try to make it as short-term as possible because of the risk of dependence. Okay, it doesn't take long, just a few weeks of benzodiazepines and people can develop dependence already. So you want it short-term. Okay, good. I hope that answers your question, Amindaran.
Yes, doctor. Thank you.
Yeah, good. Okay, anyone else have any questions? If not, we move on to the next thing. All right, okay, carry on.
Morning, doctor.
Morning. Yeah, so just do the relevant things as briefly as you can, okay? So just an overview of it so we don't overload ourselves.
To diagnose schizophrenia, we need
Okay.
at least 2 or more of the following criteria, which is either delusion, hallucination,
disorganized speech and grossly disorganized behavior, and also negative symptoms for a duration of at least 1 month. So for the negative symptoms, it's as listed on your right, anhedonia, where they don't feel there's no ability to feel pleasure in normally pleasurable activities, and then their effect is quite flat. They don't react much, and then evaluation, where they have lack of motivation to do any task, and then attention is quite poor, and in allogia they have poverty of speech. So to diagnose schizophrenia, we have to rule out other major disorders as well, like delusional disorder, because in delusional disorder, to diagnose a patient with delusional disorder, there must not be any criteria of schizophrenia. So there are few types of delusional disorder, like erotomanic, where they believe that someone is in love with them, grandiose, where they believe that they have great talent or superpowers. Somatic is physical delusion. Persecutory, where they believe that someone people are blaming them or taking their ideas, uh, and jealous, and also mixed type. And then other diseases that we should consider ruling out is major depressive
So hang
disorder.
on. So hang on. Delusional disorder, no hallucinations, okay? If you go to the exams and you have a case of delusions, very, very strong delusions, no hallucinations at all, please don't diagnose schizophrenia. This is true story from previous FPEs before, okay? That if you have a delusion only, you don't have hallucinations, we can't one, you see, number one, number two, and number three are mandatory in the DSM criteria, kan? So hang on, typical fine. Yes, 1, 2, 3, kan? So you cannot diagnose schizophrenia without the hallucinations. Understand? If you get that, then you think about delusional disorder instead. Okay? So carry on. Kritiga, you are going through the different systems actually. In that sense, the 6 domains that I told you guys about, right? Yeah.
Yeah.
Carry on.
Okay, so I will be moving on to the typical physical findings in a schizophrenic patient. First off, we have to start with vital signs and also BMI to rule out any metabolic syndrome, because that affects our management later on. So
Good.
typically in a schizophrenic patient, they have a very disheveled appearance where they look unsanitary or very untidy, and then they have a very flat effect, and then their thought process is very much disorganized, and then their procedure, memory, and orientation might be intact, and patient might have active auditory hallucination or paranoid delusion, and then they might have ideas of reference, and also they will have a poor insight about their diseases. Okay, so moving on to investigation, the BMI shouldn't be there, sorry about that. So we have to do a baseline workup to rule out organic causes, and also
your BMI
sorry.
can. Don't worry, your
Oh.
BMI can be there. Vital
Okay.
signs and BMI can be here, kan? Because you can have weight gain on the management for in the treatment of schizophrenia with antipsychotics, you can have weight gain. So BMI is fine. Good.
Okay. Baseline workup like food blood count, LFT, renal profile, thyroid function test, fasting lipid and glucose. This is both to rule out the organic causes and also a baseline before starting the antipsychotic treatment. And then urine toxicology screen to rule out substance abuse in this case. And then UPT in female patients before starting treatment. And also CT or MRI brain if indicated. So
Yep.
for
So hang on. When you look at it, that is biochemical investigations. Then you guys have done the imaging. Okay. What is a CT brain for? If you think about the CT versus the MRI. Anybody? If you have like some brain injury, concussion 10 years ago, would we do a CT or an MRI now?
MRI.
Anyone? Yeah, an MRI, okay? Because an MRI is for soft tissue injury, things like diffuse axonal injury that you want to see, very, very fine injury, we think about MRI now, okay? But a CT brain now is for 2 things. Anybody? What would we be thinking about finding on a CT brain?
Frontal lobe tumor.
Yeah, so one thing is you look for 2 types of things. What is acute and what is gross. So a gross tumor, a gross space occupying lesion, you think about you can find on the CT brain. The other thing is something acute, like a stroke, like swelling from an infection, right? Things like these are acute. So the CT brain is used for something that is acute and something that is gross, right? But anything that is fine and you expect like some long-term damage, long time ago, that kind of thing, diffuse axonal injury, things like that, we do an MRI. Okay, now under your investigations, there's also one more component, which is the psychological test. Anything we can use for this patient, I mean for schizophrenia.
We could use the positive negative syndrome scale for schizophrenia.
Yeah. So positive and negative symptom scales, the PAN score, or the brief psychiatric rating score, the BPRS. These are two that you can use for psychosis lah. Okay, and then when you look at Kritiga's differential diagnosis here, you're actually going through all the domains. It's very clear. So if you think about things in terms of the domains, kan, then you will find that it's much easier to look at psychiatry in that sense. Okay, all right. So you have covered actually 6 here. See, the mood disorders, you've covered anxiety, you've covered substance, you've covered the medical conditions, and then you've covered dementia as well. So elderly, and then you've talked about you've talked about all of this. Okay, good. Carry on.
Okay. Moving on to pharmacological treatment, we have antipsychotic medication, which can be divided into your typical and atypical. So your typical is first generation, which consists of chlorpromazine or haloperidol. So the thing about first generation or typical antipsychotic is that it primarily antagonizes your dopamine. So they can treat positive symptoms mainly with minimal impact on the negative symptoms. But then the side effects includes your extra pyramidal symptoms like you can have dystonia, spasm of your face, neck, and tongue, or Parkinsonism-like symptoms, or akathisia, where you feel very restless. In typical antipsychotic medication, they can also give rise to your neuroleptic malignant syndrome, which will be discussed later on. Okay, so your second generation is your atypical, which consists of clozapine, olanzapine, quetiapine, and risperidone, and many other more. These medications, they antagonize your serotonin and dopamine receptors. Unlike the typical antipsychotics, second generation gives rise to metabolic syndrome, like increase in cardiovascular risk, diabetes mellitus, and also elevated blood pressure. So that is that. And then for clozapine is reserved for if the patient failed to improve with typical atypical, and then we opt for clozapine because clozapine has a risk of agranulocytosis. So we would have to take a full blood count weekly for 18 weeks and then continue taking full blood count monthly.
Yep.
And then for non-pharmacological, then we can have a behavioral therapy, which can include family. We can include their family to counsel them, or group therapy, and yeah.
Okay, good. So when you look at that, is there NMS can occur in second generation antipsychotic also, it can still occur. Okay, but that's pretty much it. You look at second generation, they antagonize serotonin and dopamine receptors. So that's why in bipolar disorder, some antipsychotics can be used to sort of like stabilize the mood faster. All right, because the second generation antipsychotics do have some mood stabilizing effect via the effect on serotonin. Okay, for psychological therapy, what kind of behavioral therapy are we considering here? Anybody? What kind of psychotherapy can we give?
Is it to
Anyone?
improve the patient's ability to function in the society?
Yeah, but what kind? What kind? Because behavioral therapy is like so broad, right? If I reward my child with stars for making good behavior, and I punish for bad behavior, that's also behavioral therapy. So behavioral therapy is huge, right? What can we use? Anybody want a chance guess on what we can use? What psychotherapy can be used for psychosis? Anybody? Chance a guess? What's the most common psychotherapy out there?
CBT?
Yeah, okay. So for all patients, we psychoeducate, right? But then for psychotherapy specifically, sometimes we use CBT. But the thing about CBT is it's not something that you use now. Okay, when the patient is still psychotic and everything, you need to treat first. CBT for psychosis is something that is used later on, like say when the patient is treated already, more stable, but they still have these ongoing delusions, right? So the CBT works on helping the patient to identify that this delusion is part of me being unwell and it's not real. Like it's not true that my family wants to harm me, right? It's a CBT for psychosis, which is done later on in the course of the illness. Okay, if any of you has watched Russell Crowe's A Beautiful Mind, that is pretty much what he's doing. It's almost like a self CBT for psychosis. All right, so but that the role of CBT is much later on in these types of cases. And of course, like you say, socially lah, family, group therapy, supported employment is another one, like say employment. All right, these are all part of social therapy as well. Support groups, family intervention, if the patient has issues with finding a job or helping with getting employment. Supported employment is one thing you do. Work training via occupational therapy for work training is important. Okay, another thing under social, if a patient can't come to hospital or doesn't want to come to hospital, then what can we do?
Home visit.
Yeah, so refer to community psychiatry. That's another management under social that you can put in. Okay, now if the patient refuses to take oral medications, what are there other options?
Can give them Depo.
People,
Depo is one. Depo is one. In fact, we always use Depo as like a punishment. Ha, tak nak makan ubat, kita bagi ubat inject. And actually, Depo is a very convenient solution for some patients who refuse to. It's actually an option for patients who don't like to take medication. They just go for their Depo monthly and that settles it. Okay, so Depo is one. In some cases, some families do give medication secretly lah to their family members, but it's enough for you to know that Depo is another option lah. Okay, good. Any questions? I think there's someone asked what is the indication to send patients with schizophrenia for CT brain to rule out brain pathology. In an ideal world, we should scan everyone, I would say. But in these cases, where only two lah, I think. One, if you suspect any organicity, if the onset is a bit different, the schizophrenia symptoms are quite atypical, you have any neurological signs, send for CT brain. The other thing is, if you find that they are responding very slowly to medication, then down the road you can consider doing a CT brain as well. But ideally, if you suspect organicity, you should do a CT brain. In fact, I would prefer that we do it for everyone if we can. Okay, good. Carry on.
Doctor, sorry. Before we move
Yeah.
on, right, can I ask you one
Yeah.
more question?
Sure.
Regarding the first generation and second generation of okay, right? So,
Yeah.
which one do you prefer to start first? Second generation.
Of course, second generation.
So
Yeah.
we
Second generation is newer
so we
and
only using the typical.
rare. We do use in specific instances. Okay, if your patient is currently long time already on first generation and they are doing well, there's no reason to change. Okay, first generation and second generation are similar in terms of effect. The effect is similar, but the side effect profile is different. So the side effect profile of the second generation antipsychotics are actually lesser than first generation antipsychotics. So we tend to use second generation first. Okay, but if your patient is doing very well on first generation, we don't normally change lah. Yeah, so nowadays we start with second generation first. There are a few special instances in which we start first generation. For example, say in complicated patients in medical ward who have a lot of medical illnesses and who have like heart issues, cardiac issues and things like that, but they are delirious and they need a short dose of antipsychotic to just settle down the delirium, the agitation and all that, settle it down. Then sometimes we do use haloperidol straight away, short small doses lah. But most of the time, if you're talking about schizophrenia as in psychiatric disorders, we will start with second generation first. Yeah, so your answer should always be, I would say in most cases, second generation first.
Let's say, doctor, if the patient presented to the EPD, right, then the acute phase where the symptoms are quite severe, so we give haloperidol first, right? So if the patient respond very well to the haloperidol, then after that, can we just continue with the typical antipsychotic?
No, when you talk about giving haloperidol like that, that is a parenteral haloperidol, right? Yeah, that is parenteral haloperidol, so it's like for settling down the agitation quickly. Yes, in those cases, we do give parenteral haloperidol because in Malaysia, we don't have parenteral second generation antipsychotic. You don't have IM olanzapine, you don't have intramuscular quetiapine, you don't have all these. So you don't have it. So that's why we give haloperidol actually. Overseas, you will find that people give IM olanzapine and IM lorazepam anytime. So they can opt to give that also. The reason we're giving it here is because haloperidol is the one that we have available. So we tend to give haloperidol, yes, but we still don't continue on it because the side effect profile is quite great. Giving one dose like that does not ensure that they will tolerate the daily dosing. No. So at the end of the day, you still give second generation antipsychotics unless there's a very clear problem that makes them unable to take second generation antipsychotics. But most of the time, you can find one that works. Does that make sense?
Yeah.
Yeah.
Understand.
Okay.
Thanks.
All right. All right. Some examples to differentiate delusion and hallucination. Maybe one of you can answer this. Can someone answer it?
In delusion, it's usually non-bizarre, and in schizophrenia, the hallucination is quite bizarre.
No, hang on. Delusions and hallucinations are two different things, right?
Okay. Delusion
Uh-huh.
is fixed false belief.
Yeah. So it is a belief, right? I believe that this and that. I believe that this and that. Like I have a lot of these type of ideas, right? What are hallucinations? How about hallucinations? Anybody?
It's
a sensory
actually a
perception
perception.
without external stimulus.
Yep. So a perception without external stimulus. All right. So if you um, um, you perceive, meaning you use your senses. You see something when there's nothing there. You hear something when there's nothing there. You taste something when there's nothing there, right? So any one of your five senses, you feel something crawling, but there's nothing there, right? What other senses? Sight, sound, taste, smell. You smell something when there's nothing there. Okay, so there needs to be an engagement of the five senses to say that's a hallucination. Yeah, and a delusion would be a belief lah, an issue of belief. Okay, I hope that answers the question. It's two different things. Okay, if you hear or you see or you smell or you taste or you feel something on your skin, that's hallucination. When you think something and you believe it without any of these other things, you really believe something, then that's a hallucination. Then that's a delusion. Sorry. Does that make sense? I hope that clears it up. Okay. All right. Overvalued versus delusion. Okay. What is the definition of delusion you guys said earlier?
Fixed false belief.
Yeah. So how do we determine whether a belief is fixed? There's a few
Analyze.
criteria.
Evidence.
Yeah. Okay. Wait. There's a few criteria. Number one, it is fixed. Number two, it is false. What is the following criteria? There's a further panjang-panjang punya explanation. What is it? Fixed, false belief. What?
Despite evidence.
Despite evidence to the contrary. And then number four,
Do
one
not
more
make
extra.
sense.
No, not necessarily. Sometimes it makes sense. Some delusions make sense. What is it? What about culture?
Individual's culture background
Yeah. So what is it?
do not make sense within the context of individual's culture background.
So the context, it is out of context to the individual social cultural background. Okay, so how, if somebody tells you that they think something, how will we differentiate a delusion? Okay, I tell you that I can heal people. How will you fulfill these four criteria in asking me, in trying to establish whether this is a delusion or not? I tell you I can heal people. How do we determine whether it's fixed? Anyone? How can we determine whether my belief is fixed or not? Yep. How sure are you, right? 100%. Try not to argue, please. Uh, you want to build rapport with the patient, right? So you can ask, how sure are you? 100%, blah, 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 right? Nope, not hearing. This is not a hallucination, right? Guys, this is not a hallucination. This is a delusion. Say, okay, when I tell you I can heal people, you ask me whether I can hear about it. Did somebody tell me? Or okay, you want to determine whether it's hallucination. If I say it's not, this is a delusion. This is possibly a delusion. So how do we determine whether it's a delusion? One, you have to determine whether it's fixed. You can ask whether you're 100% sure or not, right? How sure are you? What proof, what evidence do you have? Blah, 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 right? Number two, what evidence do you have, you ask, right? And how do you believe it and all that, right? And do you believe it all the time? I mean, how much do you believe it? How do we determine whether it's false? Anybody? How do you determine whether the belief is false or not? I tell you I can heal people. How do you determine whether the belief is a false belief? Ask family members and friends. Yeah, ask family and friends, right? Collateral history, right? Who knows? Actually, the family says that she has a gift of healing people. Then you can't really say that this is a delusion. Okay, you need to determine whether it's false. Another way to determine whether it's false is to ask, okay, who have you healed before? If I tell you that I went and healed like President Trump in the US and I've never even been outside of Malaysia, then it doesn't count, right? It's probably false. So any success, but any proven success or not. Maybe she will tell you that, oh, I healed 10 people in the kampong, and you cannot verify that, right? So in that case, you want to see whether it's false or not by asking the relevant questions. Mana tahu the family say, yes, this person actually healed 10 people in the kampong before, then you will not fulfill the criteria for delusion also. Okay, so that is the second one. Then the third one is held against evidence to the contrary. So how do we prove that? What can we ask to determine that? I hold the belief despite evidence that is not true. So how can we tell? Anyone? That's the third criteria for a delusion. Yeah, so what are examples of questions we can ask? If I say I can heal people, and you want to see whether I will still hold the belief despite providing evidence apart from it. Or I give you something easier, like say I believe that there's a microchip in my brain. How do we determine criteria number 3? Yeah, someone tell you that you don't, do you change your mind? Someone, not just someone, but it has to be someone of authority. So say if the doctor scanned your brain and found that there was no microchip there, would you still believe it or not? And that's an example of a question, okay, for criteria number 3. Criteria number 4 is the social cultural background, which you guys have covered in the question number 2, asking family and friends, asking so when you say this thing, what does your family say? What do your parents say? What do your siblings say when you tell them this? And then you get some idea of what is socio-cultural context. If they all believe it, for example, like in certain societies, you believe in, like they pelihara the saka, right? The saka is passed down from generation to generation. You keep the saka, then you can't really consider that a delusion as well. So when you fulfill all these criteria, then you say it's a delusion. So leading to the question that you asked earlier, an overvalued idea would be something that the patient truly believes that is a bit strange, but that doesn't fulfill the delusion. They really believe it, they talk about it a lot, but it cannot fulfill the criteria of the delusion. But they talk about it so much that you feel like it's a bit abnormal. Then we call that an overvalued idea. Understand? Are we clear? Very clear, huh? Okay. So if you ever want to say that somebody has a delusion, the delusion must fulfill this criteria. During the exam, you must ask these questions to show that you are trying to determine whether this is a delusion or not. If you don't ask these questions and you just take whatever the patient says as a delusion, then you're not demonstrating that, number one. And number two, in future, when you encounter patients in emergency department, you could be over-diagnosing people as having delusions when actually maybe it's true, right? Like maybe I believe that I got injected with an empty syringe, right? And you immediately say it's a delusion, but actually I saw a lot of videos and actually didn't feel the person injecting me, for example. So you cannot just straight away diagnose somebody as having delusions without going through the proper criteria. So anything less than that would be an overvalued idea or just some persecutory belief, things like that. Okay, and it's okay to say that in the exams, you know. He has some persecutory belief not amounting to delusion. So this is points against the diagnosis of schizophrenia or schizophreniform disorder, things like that. Okay. When do we ask the patients for the first rank symptoms? Anywhere. Anywhere. You can ask first ring symptoms anywhere in MSE or history, no issue. But first ring symptoms is a way to, if the patient has first rank symptoms, the chance of the diagnosis being schizophrenia is more likely. That being said, you cannot just say, oh, no first rank symptoms means no schizophrenia. You can't say that. The ultimate diagnosis of schizophrenia is still via your clocking against the DSM-5, according to DSM-5 criteria. Whether or not they have first rank symptoms is not an issue. Okay? But first rank symptoms, if the patient does have it, it makes it more likely to be schizophrenia. Okay, are we clear? Are we okay? You can ask it anywhere.
Doctor, talking about the MSc, right? So do we need to do that during the 15-minute talking?
Let me think. You should probably check with Dr. Lai again earlier today. I don't think you do. I don't think you do. Unless you have enough time. Unless you have enough time. But even if you don't do it during the clocking, you do need to present about it later, like what you would do and what you expect to find and things like that. Yeah. So you can just take the history for the 15 minutes. If you have time, you can do some of the MSE if you really have the time. If not, just take the history. But you would need to present your mental state findings lah. You would
Okay.
need to present your mental state findings later, at least what you would expect to find and things like that. What signs would you look for in the MSE? What signs will you look for in the physical exam? You need to have some idea. Okay, I don't think you'll be expected to do MSE during the SCVE. Okay, good. Any further questions? If not, we move on. Okay, so just go briefly. What are special things for this particular condition? Okay.
Okay. Good morning, Dr. Amanda and everyone. So I'll move on with generalized anxiety disorder. So for the history, so we know the essential feature of GAD is excessive anxiety and also worry And so we can ask the patient, do you tend to worry a lot? And do you worry about anything in particular? So usually someone with GAD, they worry about a number of events and activities. And as the name suggests, it's called free floating. So they can have many things that they are worried about. So it's usually about everyday routine life circumstances.
Yeah.
And then other than that, you also ask how many days in the last month have you felt worried and how long have you felt this way? So it usually occurs more days than not, and the duration here is 6 months.
Yeah.
Other than that, so they also find it very difficult to control the worry, and then they also have associated symptoms. So out of 6 of these symptoms, they need to have 3 of these. So restlessness, feeling keyed up or on edge, feeling easily fatigued, difficulty concentrating or mind going blank, typo there, irritability, muscle tension, and also sleep disturbance. Okay. So after history, I'll move on to the differential diagnosis. So we can see down there, so anxiety disorder due to another medical condition. So these are some medical conditions that can present just like GAD. So thyrotoxicosis, pheochromocytoma, and hypoglycemia. So all of these, they can also have the palpitation, those, okay? And then next is substance or medication-induced anxiety disorder. So this can be like a medication, for example, like antihypertensive, bronchodilator, anticholinergic, anticonvulsant, NSAIDs, and also thyroxine. So medication induced, you can think of that like it can be because of the medication or it can also be withdrawal. So next is substance induced. Other than that, social anxiety. So below here, 4, 5, and 6 are all the other anxiety disorders. So how you can differentiate between social, OCD, PTSD, and adjustment disorders? Oh, I forgot to include also panic disorder. So
Super important, yeah.
yes,
So the biggest one, panic disorder, and then some of the others like social anxiety, OCD, PTSD, right? And then of course at the bottom you're going through the psychiatric systems review lah, the depressive, bipolar, and psychotic disorders. Yeah. Okay, good. So carry on. Carry on. How to differentiate briefly between the few.
okay, so briefly, this is actually in criteria F. So if you think of panic disorder, they would have anxiety or worry about having panic attacks. And then if you think of social phobia, so usually it's because they're scared of being scrutinized and also just negative evaluation about themselves. And then for OCD is because they have obsessions or other obsessions. The most common one of the common one is like contamination. And then for PTSD, so they might have reminders of traumatic events. And okay, that's all. And then the last one is just to rule out other disorders, like doctor said, like depressive, bipolar, and psychotic disorders. Then I'll move on to the MSE. So this is just a brief findings that you can find in someone with GAD.
Sorry,
So they
and
can
just before we move on, the apart from the anticipatory anxiety that you find in panic disorder, it's also the pattern, kan? In generalized anxiety disorder, the graph is like a straight graph. It's like I'm constantly anxious, right? But in panic disorder, you peak and then you go down, peak and then you go down. It's like a lot of gunung ganang like that. Okay, but the generalized anxiety, the person is up on the banjaran, very, very high up all the time. Okay, that's one. And then in OCD, you have the obsessions with the compulsions, and the obsessions are something that I experience as very intrusive. I don't want it, but I have to do it. And I feel better when I perform the compulsion. The obsession is there, and it's so disturbing that I feel better when I perform the compulsion. Okay? Yeah, good, good. Carry on.
Okay, so the MSC, so these are some findings that you can find. So when you look at them, their appearance they may appear strained, like their brow is furrowed, or they have their posture is like very tense. They may be also restless and trembling, and their skin may appear pale. They might be sweating, and then they may look like they're being close to tears. So this reflects the generally apprehensive state. Okay. So moving on to the investigation, so it's divided into biological and psychological. So blood, so we always do a full blood count. So here we can rule out anemia. So one of the common organic cause is also vitamin B12 deficiency. And other than that, renal profile, so to rule out electrolyte imbalance, especially hyponatremia, and thyroid function test, since one of our differential was thyrotoxicosis, and blood glucose also because we can think of hyperglycemia as well. For urine, so we can do urine drug tests. So this is for if you suspect stimulant use, and 24-hour urine catecholamine. So this one is you want to rule out pheochromocytoma. So especially if the patient has like headache, increased BP, and especially if they have panic attacks. For ECG, so ECG, I think one of it is also because of the QTC interval. We want to look at the QTC interval. And then for psychological test is Hamilton Anxiety Rating Scale. So
Yeah,
Hamilton is like,
not just QT, but the arrhythmias, yeah? Some people experience arrhythmias that make them anxious. Okay? Okay. Carry on. Hamilton Anxiety Rating Scale and Back Anxiety Inventory also can.
back inventory.
Mm.
So moving, should I explain Hamilton?
No, that's okay. That's all you guys need to know, kan? Then move on. I don't think they will ask you like, we have plenty of other things to ask you, so we won't be asking you a great deal about what the rating scale is as well. Okay, as long as you remember, for a lot of anxiety disorders and depressive disorders, right? Beck and Hamilton are two names that are options lah for you to do. Okay,
Okay.
good. Carry on.
So this one is just very simplified. So for
Good.
the management is biopsychosocial approach. So
Good.
for bio, we have pharmacotherapy. So the first line is SSRI and SSNRI. So example is escitalopram, sertraline, and the other one we can also give benzodiazepine. For not under psychosocial, but everyone needs psychoeducation. And then after that, the patient can also have supportive psychotherapy. So supportive psychotherapy is like reassurance, suggestion, guidance, and the important one is relaxation technique and cognitive behavioral therapy. So relaxation technique, we have deep breathing exercise and also progressive muscle relaxation.
Yep, I think this is a great summary of what you can go through. Okay, so psychoeducation is one. Supportive is we just listen, but we don't really offer ways to cope. Okay, and then relaxation is one more, right? Deep breathing exercise and progressive muscle relaxation, super important. All right, and these three we can do ourselves, right? But cognitive behavioral therapy is a specialized psychotherapy that must be done by a proper therapist. So in that case, the therapist is not just listening like supportive psychotherapy, but they're actually teaching new skills, right? How to deal with that, how to change our mind frame to deal with the anxiety better. All right, good, good, good. I think this is exactly what it should be lah. Yeah. So SSRI, benzodiazepine, short-term use, please. Short term as you can, and then the psychosocial management will be this. So of course, another part of social engagement is family support, family intervention if it's needed, right? If the situation is very, very bad, that is worsening this patient's GAD, you can do family therapy, right? And another one is like support groups, if there are support groups available. Good. Any questions? No questions, we move on to panic. Good. So this is the idea, okay? Just a quick overview. Okay, carry on.
Hey, good morning, doctor. Okay, so for panic disorder, the important thing that you need to ask in the history is the recurrent attack with symptoms such as palpitation, sweating, trembling, shortness of breath, chest discomfort or chest pain, depersonalization or derealization. And then if the criteria if there is a recurrent attack with more than 4 of the symptoms listed, And then next is the fear for another or consequences of attacks, such as like they're scared of going crazy. And also
Yes.
there is and then another one is the the change in the behavior to avoid the attack. And then also remember to rule out the substance use, the medical causes, and also the other mental illnesses such as specific phobia. So
Yeah.
for the
Yeah. So
physical findings,
so in this case, it's similar to the slide that Anne showed earlier as well, lah. Okay, you can use that similar time frame, but the GAD you just the similar differential diagnosis, but you just ganti with panic, right? So OCD and all that will still apply, as well as ruling out depressive. Just make sure you ask one question or two about depression, one question or two about psychosis, substance, organicity. Okay. Now, fear of another attack is called anticipatory anxiety. Okay, that's a very specific term for panic disorder, and that shows that you've done your reading, that you are aware. Okay, the important thing about panic disorder is it's episodic. It comes and goes. In between, the patient seems to be okay. All right. And another additional criteria that tends to come with panic disorder is what is the certain phobia that starts with A? Anybody?
Agoraphobia.
Yep, agoraphobia. Right? So it's fear of going outside because there's fear of what? What exactly is the fear underlying agoraphobia? Is it actually fear of going outside? Is it fear of the pokok outside? What is the fear?
Fear,
Escape is
this,
difficult.
yes.
What is it?
Escape is difficult, maybe difficult for patients.
Yes,
That's
so
what they fear of.
fearing being unable to escape or get help or to, go to a safe place. So kalau traffic jam, if it's very crowded on the escalator, right? That kind of fear. Okay, so it's a very specific type of fear. That's why the solution is not go out. So actually, it's not really fear of going out, but it's more of a fear of not being able to escape. That's agoraphobia. All right. Okay, carry on. Carry on.
yes, okay, so for the physical finding in MSE, usually the
Yep.
appearance you can see the person is restless or shaking legs.
Yep.
And then the thought also, maybe they have this depersonalization or derealization.
Right.
And the rest should be
Yep.
and then for the investigation, for the blood investigation, thyroid function test or your renal profile also can, and also full blood count. And
Before
then
we full blood count and thyroid function particularly lah. Okay, because full blood count for anemia, right? Okay. All right.
The radiology and then ECG to rule out any cardiac causes because may have chest pain, and then for the QTC prolongation also can.
So apart from ECG, when patient has shortness of breath, any other imaging you want to do?
Maybe chest X-ray.
Yeah, that's another option lah. So depending on the symptoms that the patient tells you. Okay. Good.
So for the management, for the biological, can offer SSRI, sertraline at least 8 months. And then for psychosocial, maybe CBT and also relaxation therapy like breathing exercise and also psychoeducation.
You can use that the summary that Anne provided just now lah. It's similar lah. Huh? SSRI, any SSRI lah. Doesn't necessarily have to be sertraline. Any one of it. Okay. Okay. Good. Good. Any questions? Not we move on. Okay. Next. Any questions you can just type as we go, okay? Someone asked me as well, do we need to ask suicidal ideation during clerking in every psych case, particularly in GAD cases? Yes, you ask suicidal ideation during clerking at least once in every psych case. Because if you think about it, anxiety can drive us to suicide, depression can drive us to suicide, bipolar disorder can drive us to suicide, schizophrenia can too. Even some cases of very bad dementia where not dementia lah, geriatric depression it can lead you to suicide as well. So there's quite a number of things. It's good to do a screen through lah for suicide. Yeah. Depersonalization and derealization. Okay, anyone can tell me how we ask for depersonalization and derealization? Anyone have some good simple questions you can ask?
Doctor, for depersonalization,
A person will feel detached from him own self, meaning he become the observer of his own body and thoughts.
Yeah, so how can we ask that in a nice ayat?
Feels very detached from yourself and feel can see himself body and mind from the outside.
All right, that's an option, but that will be quite long and you will be taking up quite a bit of your time, kan? Do you see yourself as another person? Is another option. Why not ask it simply? Do you ever feel like you are not real? Do you ever feel like you are not real? That's depersonalization. Do you ever feel like your surroundings are not real? That is derealization. Finish. Simple. Okay? The idea is the reality, your reality of yourself and your reality of your surroundings. One, so you can just ask that. Do you ever feel like you are not real? Do you ever get the feeling like your surroundings are not real? And that's it. Okay? So simple. Clear? Are we clear? Are we okay?
Yes,
Yeah, good.
doctor.
All right, good. Carry on. Carry on. And can continue. Khairul, are you speaking? Are you muted? Is Khairul's mic okay?
Hello. Hello.
Ah, yes. Yeah, now we can hear you.
Okay, so now we will continue with substance use
So
disorder.
there's a lot for substance use disorder, right? But we want you to go over the general principles of how to cover, general principles of diagnosing any sort of substance use disorder. There's some similar principles. Just cover that. Okay?
Okay, first we have to know how to diagnose a substance use disorder.
Yep.
Based on I didn't include the slide. If you guys have your DSM-5 with you, you can turn on to it. You can flip to page 41, and from the DSM-5 criteria, substance use disorder are characterized by a problematic pattern of substance use causing impairment or distress, as manifested by at least two of the following symptoms within a 12-month period. So there's 11 symptom, which is a
Yep.
substance use, using substance more than originally intended, persistent desire, or unsuccessful effort to cut down on use, and significant time spent in obtaining use or obtaining, using, or recovering from substance, failure to use substance, failure to fulfill obligation at work, school, or home, continue use despite social or interpersonal problem due to substance use, limiting social, occupational, or recreational activity because of substance use, use in dangerous situations, continue use despite subsequent physical or psychosocial, psychological problem, and tolerance and withdrawal. So we need at least two out of this symptom, and it should be within 12-month period to diagnose a person with substance use disorder. Then
Yeah.
for important history, we need to ask during tracking patient with substance use disorder, which first we have to know which drug are they using, how often they use, the duration, the amount of use they use in on one time, and have to ask whether patient use single or multiple drug, and the route of use of drug, whether they use by injection or they snort it or they smoke it, and the source of drug, and we have to ask currently what drug are they using. And we also have to ask about withdrawal symptom. Withdrawal symptom actually is very specific to which drug are they using. But for example, patient might have sweating, lacrimation, sniffles. For tolerance, to ask tolerance, we can ask whether the patient do they need to increase the amount of the drug to achieve the desired effect. And also compulsion is by asking whether the patient have any urge to use the drug, and also ask them when they are not taking the drug, do they crave for the drugs? And we have to ask about risky behavior, such as sharing needle. We have to ask them, do they with how many people they share, and if they are not sharing needle also, we have to ask whether they change, do they change the needle, or do they use the same needle every time they have injection. And also dangerous injection site. Dangerous injection site, it can be at the neck, at the head area, and also at the groin area. And for abstinence and relapse, we ask them is, did they try to stop using the drug, and what influenced them to stop using the drug? And if there is a relapse, ask them what causes them to take the drug again. So look for medical and psychiatric complications such as hepatitis B, hepatitis C, HIV, any infection, and also psychotic disorder, anxiety or depression. And lastly, you have to ask about social complication. How does the drug affect their work, their school? How the relationship between the family? Any do they neglect their family, and also is there any social connected to the social commitment? And how does this use of drug affect the financial problem, plus financial problem? And also, is there any problem with banks and the police?
Yep. So when you think about it, there's a lot that you have to ask. But if you think about it systematically, you go via the DSM. Know those 11 criteria, and actually those 11 criteria will already guide you as to what to ask. The only thing that is not covered in the 11 criteria is that first point over there, which drug, duration, the details of the use, right? Maybe not really covered. But after that, right, anything else after that is covered by those 11 criteria that you need. 11 criteria for any substance use disorder. Okay? So in those cases, you can actually um, what do you call it? If you can establish that this person has substance use disorder, then you can diagnose this person with, alcohol use disorder, stimulant use disorder, one of these disorders. Yeah. So all this is actually covered in the DSM criteria if you were to ask according to that. Okay. So carry on.
And for mental state examination, first we
Yep.
will check, observe the appearance and the behavior, look for physical appearance, the state of consciousness, the cleanliness, and also the mannerism of the patient, whether they are agitated, and is they their ability to cooperate with you when you are correcting them. So for the speech, you assess the rate, quantity, and the volume of speech. Is it the coherent speech or not? Is it relevant? And for the mood, we check what the patient mood, which is what did the patient mood is what patient description is, how they feel. And for affect is what we observe then and check whether it's congruent or not. And
Yep.
for thought and perception, is there any hallucination, delusion, any compulsion? For concentration and attention, you can ask them to do the serial 7 test, ask them to minus 7 from 100. For insight, whether ask the patient have poor insight or good insight.
Yep.
Or physical exam.
So
Uh,
insight would be another part of insight for substance use disorder is to assess the readiness for change. Okay, if you remember, there's the stages of change, right? The Prochaska stages of change, right? Pre-contemplation, contemplation, action and all that. If you have not heard of this before, it's good to go and read it up. Okay, so you get an idea of where this patient is in the change cycle. Okay, because if the patient is in pre-contemplation, doesn't see it as a problem, whatever, then the kind of intervention you offer is different from somebody says, you know what, doctor, I really want to stop. I already made some moves. I already cut off my ties with my friends who are taking substance, right? Is the management is a bit different for both. What you can offer for help is quite different. Okay. So you need to know at what stage this patient is, not just the insight, but at what stage of change they are at. Carry on.
then for physical examination, because we can look for injection mark if they use injection as the route of drug administration, and also look for hepatitis such as jaundice, hepatomegaly, abdominal tenderness, look for subcutaneous abscess, and also the vital sign. For intoxication sign and withdrawal sign, this is specific to what type of
Yeah.
drug we use, because every drug have their own specific intoxication sign and also withdrawal sign.
Yeah, so the intoxication will be the effect of if the drug is a stimulant or it's a CNS stimulant, then the effect is somebody is very hyper, right? Intoxication. The withdrawal is the balik. You want to sleep more. You don't have energy to do anything. Okay, but if the drug is something like heroin, that is a CNS depressant, then the intoxication will be they are very calm, very relaxed, very slow, very content with the world, very stoned up. Okay, and the withdrawal will be all the shakes, very nervous, very agitated, wanting the next heroin fix. Okay, so the effect will be the opposite depending on what drug you're looking at. Good.
And we look like then we proceed when we have to know what drug are they using. So there's a few categories of drug, which is opioids. For example, for opioids, right, there's the common we know is tramadol, morphine, and fentanyl. But the illegal use of opioid is the common one is heroin, and is usually heroin comes in powder form, like the picture on the left one. And other than that is also a stimulant. Stimulant is a drug which induce the cardiovascular stimulation, elevate the mood, and also reduce need for sleep. So, for example, we have cocaine, amphetamine, cannabis. It's also good to know their street name, because sometimes patients won't tell they are taking amphetamine, they take cannabis. So for amphetamine, the street name is usually ice, or they call it batu. And for cannabis, it's usually they just mention it's a weed. They smoke weed.
Yeah, okay. So the thing is be a bit careful. Cannabis in this case has some stimulant effects, but it's not exactly a stimulant like amphetamine, like shampoo, okay? Because it has some mixed effects. It's almost like ketum. Daun ketum. It has at certain it is sometimes a stimulant, it has some depressant effects as well. So it has both. So generally I put cannabis in another category lah, the cannabinoids. If you look at your urine for drugs, the test for cannabis is different from the test for shampoo and all that as well. So it's like a separate category on its own. Okay? Yeah. So it's worth remembering that cannabis is a bit unusual. It has stimulant effects, but it also is not a typical stimulant. Okay? Carry on.
Then we also have hallucinogen. Hallucinogen is substance that help to produce hallucination. And for example, ecstasy, and phencyclidine. Ecstasy is a common one. They usually call it love pill, because it also is sexualism. And other than that, we sedative and hypnotic, such as benzodiazepine, barbiturate, and for inhalant such as blue gasoline. And for investigation, important one is the urine drug screen. For cocaine, usually it can be positive until for 2 to 4 days, and vitamins for 1 to 3 days, and also for opioid is 1 to 3 days, and cannabis for 3 days, and phencyclidine for 4 to 7 days. And
Yep. So generally speaking, this can be quite how you call it? Within if after a few days already, their last use was more than a few days ago, sometimes the urine will be negative. But that means that you can still, it doesn't mean that if the urine is negative, your provisional cannot be substance use disorder. It can, because the person's last use was certain time ago. Okay, in fact, cannabis is a bit unusual in this as well, because some people who take it very heavily for many days can have a positive, for very chronic period of time, they can have a positive urine for up to, I don't know, a month maybe, from the last time they took the cannabis. So cannabis behaves a bit differently from the other drugs as well. Okay, so it's worth remembering lah. That means that if you look at this list here, right, the time frame here, if your patient's last use was sometime before, it doesn't mean that you can't use this as your provisional or your differential diagnosis. You can mention that the urine for, even if the urine for drugs is negative, it was sometime since the last use. Okay? Carry on.
Other investigation on like full blood count, liver function test, and view square. Also, we also do ECG to look for any arrhythmia, and also we have to do the VDRL test
Yep.
and HIV testing.
Yep. So biohazards, good.
And for screening, we use a drug abuse screening test.
Yep. It's for screening. Yep. Carry on.
And for management, we approach
Oops.
patient by
Hang on. Yes. Carry on.
and for management, we approach patient by biopsychosocial approach. And for biological, if patient have opioid overdose, then the antidote will be naloxone. And
Okay.
patient is using opioid, if patient have opioid use disorder, then we can use a methadone therapy or buprenorphine or naltrexone
Yep.
for opioid.
So
And
methadone is only for opioid use disorder, okay? Not for anything else. Okay, carry on.
And for benzodiazepine overdose, then we can give patient a few months and also for if patient have hallucinogen use disorder, we can use a short-term benzodiazepine.
Yeah, so benzodiazepines can be used to tide off any withdrawal lah. For most substances, including alcohol, you can use benzodiazepine to sort of like settle the person, except if the person has benzodiazepine use disorder, and that's another story. Okay, but for a lot of other cases, to settle the agitation, you can use benzodiazepine. Okay, good.
And
Carry on.
psychosocial, we have a motivational intervention and we have
Motivational
cognitive
interviewing, motivational interviewing. Okay.
motivational intervention. And cognitive behavioral therapy, we give psychoeducation and also behavioral counseling.
So psychoeducation you should put at the top because that is something you do for everybody, right? Specialized things like CBT for addiction, motivational interviewing, addiction counseling. You can do that as well for under psychological. Okay, but under social, is there anything else we can do for patients? Separately, social. Anything we can do separately for patients? Anyone? Substance use patients? Anybody? Yeah, send for rehab. Rehab's one, right? Good. The other thing is, what about support groups? You know, if you hear overseas, there's Narcotics Anonymous, there's Alcoholics Anonymous, right? And sometimes, in the family, there's a lot of conflict in the family. So in those cases, you can offer family therapy as well. Okay. Good. Are we clear? Anybody? Everybody okay? Everybody all right? Okay, this is a general overview of substance use disorder. Yeah, that is applicable for more substances. Okay, good. Carry on. Okay, alcohol.
Hello, doctor. This
Hi.
okay. My name is Yagaraj. So I'll be talking about alcohol withdrawal symptoms. So this is according to the DSM-5.
So hang on,
Alcohol test.
hang on, before you start, guys, alcohol use disorder will go under the same diagnostic criteria as the substance use just now. Okay, same one. So that's why we don't cover that. But alcohol withdrawal symptom is a specific one that you need to know. Okay, so carry on, Yegaraj.
Okay, so in alcohol we have just like other substance, we have the intoxication and withdrawal, but I'll be specifically talking about the withdrawal. So these are the symptoms. Two or more of the following after the cessation of alcohol for several hours or to few days. If we have any these 8 symptoms, then we are suspicious of alcohol withdrawal. Okay, next. Next slide. And then the sign or symptoms of category usually can cause clinical significant distress or impairment in social, occupational, and other areas of functioning. And these signs or symptoms are not attributable to another medical condition. That means we have to rule out other medical condition, and then this, so we then only we can say that this is alcohol withdrawal symptoms.
Yeah.
Okay, next. Okay, so for the history taking, first before we ask for the alcohol withdrawal symptoms, first we need to ask about the whole alcohol habit itself. So first we need to ask what type of alcohol you take. So is it a beer, wine, whiskey, or something like that? Do you take it in cans? How much do you take it? So it's like, do you take it every day? How many cans you take it, and every week do you take it? Something like that.
Yep.
And then when was your first drink? So at what age did you started to drink, and how much you drink throughout the typical day, like just now? And then when did you notice the alcohol intake started to increase, which is a tolerance. So tolerance, you either ask, there's two ways of asking. Either you ask, when did you start to increase the amount of alcohol intake, or you can ask that when did you feel that the alcohol you taken the same amount but there is no effect. So by either both, you can say that patient is already developed a tolerance. And then ask about the current drinking pattern, and then assess the impact of alcohol, biological signs of dependence, any dependence present, what time and where does the patient have the first drink of the day, how do you feel when walking, and any health complication from drinking, like liver problems and stuff like that. So, and then we also ask for psychological signs of withdrawal present. So over here we can also ask we can ask the cage questionnaire. So we can ask the patient whether he has any intention of cutting down the drinks, or does he feel any annoyed if someone asks him or talk about this addiction he has, and does he feel guilty about drinking every day. And then last thing is any eye opener. Does he drink this as the first thing in the morning just to clear his mind or get rid of the hangover? So, and also you can ask about any sign and symptoms, like just now I saw in the DSA. So you can ask whether the patient has any anxiety or any insomnia, any nausea, and then you also ask patient
Yep.
any hallucination to rule out delirium tremens, and then
Yep.
so, and then more to know about alcohol, we need to ask why did the patient start the alcohol? Is it due to a problem? So when started the need of drinking alcohol every day? So maybe patient have some kind of psychotic or mood or depression disorder, which leads to alcohol drinking to overcome his stress in his life. So we need to ask about that. And then when did they begin to drink in the morning? And then periods of abstinence from from alcohol. And then what factors maintain the state of abstinence, and what lead to resumption of drinking. Uh, so basically, we need to ask about that. And then the current situation, which is the one we need to really ask about, is how does the alcohol addiction affect their life, the relationship with their parents or wife, children, social support, working place, any problems caused criminal activity due to alcoholic, and where do they stay? Are they having um,
Yep.
a good
So
life and stuff?
so this one is generally covered under your DSM already. Okay, if you go by the DSM, they will cover everything, including your complications. Okay, so this will all be covered. If you were to know your DSM well and to follow it when you're asking, then it's very clear. Now, you are also doing a psychiatric systems review actually by just asking if there are any depressive symptoms that led to this coming about, whether there's any psychosis. You know, sometimes people self-medicate for depression and psychosis with alcohol. So if it was a schizophrenia that led to an alcohol use disorder, your diagnosis you should be identifying the schizophrenia that led to it lah. Okay, yeah. So we need to consider that. So go through a psychiatric systems review, like I mentioned just now. Okay. Then past medical and surgical history lah, the usual lah. That's organicity as well. That's part of your psychiatric systems review. Okay. All right. Carry on, Yugaraj. But just go
Okay.
through briefly what is relevant to alcohol in particular. Okay. Carry on.
Okay, doctor. So for MSc, we'll talk about the appearance. So basically, patient will have a pure hygiene or unkempt clothing, very aggressive or maybe have a sexualized behavior. So this is due to intoxication. So and then if patients having withdrawal symptoms, patient will be have fearful and paranoid, and sometimes will be restless, having tremors and agitation. And then if we have sometimes also can have ataxia due to like maybe it's due to intoxication or Wernicke's encephalopathy. And then for the speech, if it's intoxicated, patient will be having slurred speech. And for mood, patient can be either euphoric, depressed, depends on what they're feeling during the intoxication. And then withdrawal, they most probably will be irritated and anxious. And then for thoughts and perception, patient will have sometimes can have alcoholic hallucinosis, where they can feel things crawling over their skin. And then when during signs of like delirium tremens, like patient will be talking, having tangential, circumstantial, and illogical explanation and confabulations and stuff like that. So for cognition, patient will have a clouding of consciousness, and then he's also sometimes disoriented to time, place, or person, and poor planning of abstract thinking and impaired short-term memory. And the insight most probably will be poor because this is all patient is having like some CNS depression, they can't think properly, something like that.
So when you're talking about withdrawal, the main thing is to look for physical symptoms like the restless tremors, agitation, okay, the irritability, and the disorientation. If they're very, very disorientated, they're hallucinating like anything, alcohol withdrawal is an emergency. Okay, so you need to be aware that it's not just alcohol intoxication. In fact, alcohol intoxication is probably annoying, but alcohol withdrawal is the dangerous one. Okay, and there's a lot of information to know in medicine, but you guys need to know what is common and what is dangerous. Okay, what is common is alcohol use disorder. Okay, but what is dangerous is alcohol withdrawal. So you need to know. It's just like depression is common. You need to know about depression, but suicide is life-threatening. It's dangerous. So everything else you can learn on the job, but you need to know to be a safe doctor. You need to know what is common and what is dangerous. Okay, so that's why alcohol withdrawal is important. Carry on, Yegaraj.
So for biological investigation, so we need to check for full blood count because during chronic alcohol and consumption, patient can have esophageal varices due to liver impairment. So they can have bleeding, so they can have low HB, and then they also can have a microcytic, increase MCV, and then they can also have low platelet due to the heavy regular alcohol consumption. And then if you see in LFT, the GGT will be raised, and then if you see the AST to ALT ratio will be more than 1, because in liver function disease, if the AST is high, we can rule out it's most probably due to alcoholic liver disease. And then you also can do the blood alcohol concentration, and you can detect the blood alcohol in the blood. And then you can have a carbohydrate deficient transferrin, because heavy drinking may cause increase in carbohydrate deficient transferrin that functions to transport the iron. And then you can do a coagulation profile test and also blood glucose, which is due to liver impairment due to chronic alcoholic usage. And then sometimes you also can like for imaging, maybe you can I forget to put here, you can do like chest X-ray to rule out pneumonia, because patient can have aspiration pneumonia due to because they are drinking, they can just sleep and then they can just ingest whatever they just eat, and it can go to their trachea. And then one more thing is and also can do like CT brain or something if they come with like, can have head injuries. Maybe they be walking and then they can't walk properly and they fell down and hit their head and stuff like that.
Yep. So
And
what
then
so the time frame is important lah, whether you consider whether to do city brain or not also. Whether you're dealing with some other issue apart from alcohol withdrawal. Carry on.
for psychological investigation, we have the just now of the case questionnaire, and then we have two things. One is the audit questionnaire. This is for the alcohol use disorders identification, but for For withdrawal, we have specifically CBR, the Clinical Institute of Withdrawal
Yeah,
Withdrawal
CIWA,
Symptoms.
CIWA,
CIWA.
okay?
Yeah.
CYAR, okay?
Yeah.
Yeah, so good, good. CIWA is super important, or alcohol withdrawal scale, one of these two, okay? And a CIWA is what you use to detect withdrawal in the ward, and you monitor withdrawal. So you detect withdrawal, give benzodiazepines, and then you observe, you have to do CIWA at certain intervals and watch the CIWA go down, hopefully. If it continues to go up, you need more benzodiazepines to cover the alcohol withdrawal. Okay, so you see your withdrawal timeline down there, super important. If somebody presents to you, like say 1 week or like 10 days after the last drink, and people think it's delirium tremens, is it likely? It's probably less likely, because you notice that the onset, the specific onset of alcohol withdrawal is especially within the first 48 to 72 hours, especially. So from the last drink lah. Okay, so that's why some patients, you see, they come in and they're okay, they drank, got drunk, had a road traffic accident, came into the hospital, were okay, very cooperative and all that. And then after that, day 3, then they started going downhill, hallucinating, talking nonsense, cannot really understand, don't know what time of the day it is, right? In those cases, you need to think about alcohol withdrawal. Okay, but say it's like been 10 days in the ward, the patient was super okay throughout the 10 days, and suddenly he's disorientated. Is that likely to be alcohol withdrawal? What do you think? Suddenly, after 10 days, then he's like that. It's much less likely. Okay, in those cases, you should think about delirium. Delirium secondary to some blood loss somewhere. Maybe the HB is going down. Maybe his electrolytes are all over the place. Maybe he's getting a temperature. He's getting an infection in his body. So it's a delirium secondary to something else, more likely. Okay, because alcohol withdrawal has a very specific time frame. A certain set number of days without alcohol, 2 to 3 days without alcohol, and the onset starts. Are we clear?
Yes, doctor.
Yeah, if you're clear, can carry on, yeah, Garage.
Okay, so the management, there's a pharmacological therapy first. So we will give benzodiazepine. It acts as like a substitute to reduce the withdrawal symptoms. We also can give carbamazepine, and then they also can give promethazole, but nowadays they don't use it due to high toxicity. And then we need to give vitamin supplements such as thiamine to prevent this Wernicke-Korsakoff syndrome.
Yeah,
And then
so
for
enough to say benzodiazepines and thiamine. Full stop. Okay, and then
And
you
then
rehydrate. Make sure your hydration is good, because hydration, nutrition level, vital signs are good. That's for biological therapy lah. Okay, carry on.
And then for psychological treatment, we have 3 treatment. One is the Alcoholic Anonymous. And then the second one is the stages of change, the pre-contemplation, contemplation, preparation, action, and maintenance. And then the last one is motivational interviewing. So we allow the patient to voice their own reason for the change, and then we listen with empathy, more like we listen to whatever the patient say. And then lastly, we have a biological treatment. They have disulfiram, acamprosate, and naltrexone. So disulfiram is actually acetaldehyde.
Yeah. We move on, Garage. Your colleagues
Okay,
should be
sure.
able to read up and learn that on their own.
Okay.
Let's move
All right.
quickly.
Okay. And then last one is the treatment for delirium tremens. It is the same thing. Just give benzodiazepine, fluid replacement, thiamine, avoid psychotic, and also once stabilized, the benzodiazepine can be withdrawn after 10 days. Yeah, that's all, doctor.
All right. So, okay, we need to be very clear. Let's talk just about alcohol withdrawal here. Alcohol withdrawal here, you treat just like this delirium tremens, okay? We don't have many IV benzodiazepines here. So we generally tend to give oral, okay? The other issue with IV is the onset is fast, but it clears from the system quickly. We want it to have a longer lasting effect, because why? The patient needs to be covered the entire day to prevent the withdrawal symptoms from coming out. Okay, so we do give oral benzodiazepines, okay? You need fluid replacement, you give thiamine, okay? These are all actually under biological treatment, okay? Antipsychotics can be used if the hallucination is very bad. You may consider it. But in a lot of cases, benzodiazepine is enough because when you stabilize the withdrawal, then then it goes away. Then the hallucinations go away. Okay, then slowly you have to withdraw the benzodiazepines. Okay, that is all actually under biological. All right. Now, biological long term will involve medications like disulfiram or acamprosate and all that for to reduce the addiction, the craving for the medication. The problem is you need to know at what stage of change the patient is. So in fact, in the management of any substance use disorder, you must know the stage of change. If the patient has no intention to stop drinking, even after this massive delirium tremens episode or this alcohol withdrawal episode, no point giving the long-term biological treatment. Okay, we want to know the stage of change. If they're highly driven, then yes, we can give the biological treatment long term. If not, the biological treatment is confined to the time in the hospital. Benzodiazepines, thiamine, and the antipsychotic if needed, fluid replacement, make sure the patient is hydrated, make sure the CWA score goes down. Okay, so from knowing the stages of treatment, stages of change, sorry, the Prochaska stages of change, then you can go and suggest, okay, does this patient need Alcoholics Anonymous, or can we do motivational interviewing? Can we do something even more aggressive, like addiction psychotherapy, something like that, you know, that's psychologically. And don't forget social. So social will be things like support groups. Alcoholics Anonymous will come under this, as well as engaging the family. Okay, remember, try to separate psychosocial, because when you separate psychosocial, then you remember the social part, and then you can get more marks. Okay, when you lump psychosocial together, then sometimes we miss out the social part, which is family engagement, you know, helping the patient with employment, occupational therapy, um, things like support groups and things like that. These are all for more marks for you guys. Understand? Are we clear? Okay. All right, okay. I have no intention of keeping you guys between 1 p.m. So beyond 1 p.m. because you guys would want to have lunch and all that before the simulation. So the thing is like there's some of the remaining topics. I mean, it's less likely to come out in your in simulation and all that lah. So we can always talk about it later. Okay, we can carry on until 1, and then the remaining disorders, what we can do is either at the end of simulation we can cover the rest, or we can arrange another day to quickly cover the rest, which probably will not take so long. Okay, so I intend to just like to make sure you guys have your lunch break and stuff. Okay, thank you, Yagaraj. Yeah, all right, any questions so far? Anyone?
Doctor,
Regarding alcohol, yes.
regarding alcohol.
Oh,
No,
oh,
actually, my question was, since you said the previous topics are more likely to come up for SBCE, right?
no,
So
it's more likely to come up for simulation today, not necessarily for SBC. For your simulation this afternoon, I mean. Yeah, but you
okay,
wanted to ask what? Do
yeah,
you still
regarding
need to
the
study the others?
yes,
No,
yes,
no, no.
yes.
No. I'm just giving you guys the allowance for lunch, or you guys want me to torture you until 2 o'clock for simulation, right? No. As in we cover the big disorders prior to this, okay? But some of these others are still possible. All right. So are still possible. It's just that maybe like in simulation we want you to do the common ones lah. All right. Okay, any questions? No, if not, we move on.
Doctor, can I ask about schizophrenia?
Yeah, go ahead.
What are the cognitive symptoms of schizophrenia?
Where did you get where did you get that term? The cognitive symptoms? Where is this coming from? Because the
Where is
source,
this
if you read
coming
it, should
from?
have given you examples, right?
Mm, uh,
I need to
I
know
also don't know.
I need to know where your question is coming from, you see, so that I know how to answer. I know what exactly you're looking for. What do you mean?
Um, I should it's okay lah, doctor.
Yeah,
I
yeah.
also
I mean, is it because you notice that other disorders have cognitive symptoms, so you are asking this, or is it that you've read it somewhere and they didn't explain it properly? Like, that's why I want to know actually where it's coming from so that I can answer you more clearly and not out of context. Yeah. So is there
I
anything in particular that you're worried about or what?
I think I read it somewhere, but I did not fully understand.
Yeah. Yeah. So cognition is basically anything to do with the brain, right? How you process and your memory and things like that. So cognitive symptoms will be anything related to that lah.
So is it like memory? Is
Yeah.
it something like that? Okay.
Yeah, I mean,
Yeah.
if you think about cognition, what else is there? It's not just memory, right? It's your ability to make decisions, it's your ability to plan and things like that. So
Okay.
anything that it affects your brain functions and your thinking and your planning functions would be cognitive symptoms lah. So whether it
Okay.
occurs as cognitive symptoms in depression or anxiety or things like that, uh, yeah, it is the
Okay,
same.
thank you, doctor.
Mm. All right. Okay. Carry. Good. Any questions? Any further questions? If not, we carry on.
Hello
Yep.
everyone.
Let's go briefly as a brief overview of things. Yeah.
Okay. Hello everyone. I'm Azira. I will explain about EPS, extrapyramidal syndrome. So basically, EPS is side effect of antipsychotic drug. Typically the first generation antipsychotic drug. This is due to it act as an antagonism at the
Okay,
brain.
we've covered this before, right? We've covered this
Okay.
just now when we talk about typical and atypical antipsychotics. Move on.
Alright. Okay. So uh, there are some neurological side effects on antipsychotic drug. The first one, very important one, is EPS. This is due to this blockade of dopaminergic activity in negrostriatal pathway in the brain. So it can cause three things. The first one is acute dystonia. Acute dystonia is characterized by intermittent or most commonly sustained spasm of muscle of tongue, face, neck, and back. It is usually painful. So the patient usually presented with oculogyric crisis if acute dystonia affecting the ocular muscle, torticollis or retrocollis if affect the neck muscle, and the patient can come with backward arching of head, neck, and spine, which is called opistotonus. It is higher risk in younger patient, male patient with antipsychotic naive and also high potency agent. So for
Yep.
management of acute dystonia, we can use intramuscular anticholinergic drug, which is procyclidine, 10 milligram, and we can add on other anticholinergic drugs such as benhexol, and we have to reduce the offensive drug and change the medication, preferably a second generation medication. So the second
Good.
one is akathisia. It is characterized by inner restlessness where the patient need to do movement to feel better. For example, shifting weight from foot to another foot, rocking their body while sitting or standing still. So this actually acute dystonia, this EPS is the onset is acute, which within 1 week after administration of drug. So if the patient have akathisia, we can give the management. The management is to reduce the dosage, and we also can give propranolol to reduce the involuntary movement, and also benzodiazepine to reduce the anxiety. The last one, the last EPS is pseudo Parkinsonism. This is the same like medical Parkinson, which characterized by rigidity, tremor, bradykinesia, and later can come with postural instability. And also, patient will have mask-like faces. So we can reduce the dosage gradually and add on anticholinergic drug, which is benhexol 2 milligram BD, and switch to second generation drug. So the last side effect of
Good.
antipsychotic
Good.
drug.
So sometimes we sometimes put them together, tardive dyskinesia as well. Yeah, just so you can remember four. Okay, so that's good.
Okay, doctor.
I will be a bit careful with the onset because sometimes some patients have it like after 1 week, or some patients have it like after a few months on the same medication. So it is some usually observed within the first week, but it can occur later as well. So you have to be a bit mindful of that. Okay, carry on.
Okay, doctor. Okay, for tardive dyskinesia, tardive itself mean delayed. Dyskinesia is abnormal movement. It is due to D2 receptor hypersensitivity. This is the difference between EPS and tardive dyskinesia. The patient will, the presentation is, the patient can have repeated involuntary movement of lips, face, trunk, tongue, and extremities. So we can see the patient sometimes might have lip smacking, chewing, or fly catching tongue protrusion, and so on. So it developed in months to years. It is often irreversible and get worse if the drug is stopped. And elderly have 5 times higher risk than younger patient. So as this is irreversible and the patient might become more worse if the drug is stopped. So we can reduce the offensive drug slowly and change to second generation antipsychotic.
Yeah. So we can get worse if the drug is stopped very abruptly. So we reduce slowly. Slowly is the word lah, and we go from there. Okay. Good.
Okay.
Good. Good. Okay. Any questions? Are we okay? Okay. This is a great overview lah of EPS. Okay. All right. Good. Then we move on. Nobody has any questions? We move on. Yeah.
Okay, so good morning, everyone.
Yep.
So I'd like to talk about neuroepileptic malignant syndrome. So this MMS is a life-threatening psychiatric emergency. So it's usually caused by the high potency antipsychotic. So it can be either first generation or second generation. So these four clinical features are the tetrad of this NMS. To remember this, it is a fever, muscle rigidity, like what you can examine in Parkinson patient punya rigidity, and the next one will be autonomic dysfunction such as tachycardia, level blood pressure, or any diaphoresis, and the last one is the altered mental status. So for why is this happening is because we have this high potency antipsychotic. As we know, this antipsychotic is the dopamine agonist. So this drug will cause a sudden hypodopaminergic state, which increase the temperature set point in hypothalamus, which then causing this fever. And then besides that, because it's inhibition of this nigrostriatal pathway, this will cause muscle rigidity like in the pseudo-Parkinson just now. And due to the reduced dopaminergic inhibition of this system, the sympathetic nervous system will cause our sympathetic nervous system to be hyperactive. So this will cause the autonomic dysfunction such as like the diaphoresis, tachycardia, level BP, and also some tremors sometimes. And then because of this dopamine, it will also increase the calcium release. So as we know that calcium plays a big role in muscle contractility. So because as the calcium release more, this muscle will contract more. So as the muscle contracts more, this will lead to elevated creatine kinase. So this indirectly will cause rhabdomyolysis, which further might cause AKI. So this is why this is a life-threatening psychiatric emergency. So for the expected laboratory findings, the most important one is there will be increase in white blood cell, elevated creatine kinase due to the muscle cells breakdown, and some metabolic disturbance. And the complications such as rhabdomyolysis lead to AKI, seizures, cardiac arrhythmias, or even DIC. And for the management, first, you need to remember to first discontinue what is the cause of this condition, which is the antipsychotic drug. Then the next one will be supportive measures such as because the patient present to you with fever, so you must rapidly cooling the patients or give enough hydration. And then the most definitive treatment is the pharmacological treatment. First is the dopamine agonist because you are giving antipsychotic, which is the dopamine antagonist. So to reverse this, you need to give dopamine agonist, which is bromocriptine. and also dantrolene. This dantrolene is to inhibit further muscle contractility, and also sometimes we can give benzodiazepines if the patient is like very aggressive, and plus minus ECT.
Right. Okay. Good. So it is generally one where you need to get medical care on board, like general medicine to come and help us co-manage, and it requires ICU care lah. So it is an emergency. Okay. Good. So you need to be a bit careful. Like if say a patient is just admitted and then was given antipsychotics, right? Like say because sometimes this can come out in exam questions as well, right? Your written exam and things like that. So if a patient presents in this way, something to consider is actually neuroleptic malignant syndrome. So this is one of the dangerous things that you need to know. Okay, we know what is common and what is dangerous to make us ourselves a safe doctor. So this one is another dangerous thing in psychiatry that we need to know. Okay, so mortality rates are quite significant, especially if not treated. Okay, good. All right, so by right, you guys have actually another 4 topics, which I think you guys should actually take a break first. Take a break. What do you guys think? Take a break before your simulation in the afternoon, and then we will see when we can squeeze in our remaining 4 topics lah. Can ah?
Okay,
Okay.
doctor.
All
Can.
right. Good, good.
Can,
So you
doctor.
take a lunch break first. Make sure you eat properly. They will probably need 2 or 3 people to test, to do the clerking for the simulation later. But you guys, I suppose you guys should have arranged who to do it. Dr. Lai will be joining us for the simulation this afternoon. And then we'll go from there. We see what time we finish, whether you guys want to proceed with the remaining 4 topics or we try and arrange another time. Okay. All right. Thanks, guys. If you think of any questions, you can ask as well later. All right. Then we'll go from there. Okay. Thanks. Have a good lunch. I'll see you guys later. All right.
Thank you,
Bye.
doctor.
See you, doctor.
Thank you,
No
doctor.
worries.
Thank you, doctor.
No worries.